We're so thrilled to have all of you here. Looking back on the past 2 days, I think we really made the most of our short time together count between our social outings and all of our clinic visits. We've accomplished a lot, and I think we should all be proud of our contributions to the success of this clinic, you as the patients. We each sacrificed a lot to be here. The travel with our Dessh loved ones is not easy. The time away from work, the time away from our other family members at home, and the expenses we incurred are not little sacrifices, so I want to give all of us a round of applause. Of course, we have a lot of other people to thank for this conference. So we had a ton of sponsors, and I'm going to go through them, and I want you to bear with me because I think it's important that we list everybody. So first and foremost, thank you to Washington University and St. Louis Children's Hospital. I want you to know that WashU is a recognized center of excellence for rare disease by the National Organization of Rare Disorders. So we are very fortunate to call this place the home of the Dessh Clinic. Of course, thank you to the medical team at WashU, including Dr. Patty Dixon, she's director, and Dr. Marwan Shanawi, professor of pediatrics for the Division of Genetics and Genomic Medicine. I also want to thank the doctors who volunteered their time to see us at the clinic. This is not an exhaustive list, but Dr. Shanawi, Dr. Weisenberg, Dr. Reynolds, Dr. Mayerson, Kathy Sisko, RN, and all the clinic staff who assisted us in the PCRU. Thank you to all the clinic coordinators at St. Louis Children's Hospital who planned this many, many months in advance. Dana Kiley, Yolanda Phillips, and Kathy Sisko again. And finally, I want to thank everyone that donated or provided some sort of discount for our events while we were here. That includes, these are all St. Louis businesses: Sugar Fire Barbecue, The Shack, Kendra Scott, Whole Foods Market, Chick-fil-A, Ted Drew's, City Museum, and Colleen's Cookies. And I also want to make a huge thank you to Emily Smith and to Susan Ford for all of the coordinating and organizing that they did to make this happen. It's been, I think folks who were here last year noticed a difference between last year and this year's conference in terms of the hospitality we received in St. Louis. Dessh community members Stephanie Salam and Melissa Sidebottom, you guys helped out with some pre-clinic stuff, and that was really appreciated. And of course, thank you especially to Colleen Tosti for her months of planning and preparation with me leading up to this event. And a special thanks to my husband, Joseph, for his support. There's a lot of late nights, and he held it all together for us. And last but not least, I want to recognize our Dessh Board of Directors for their commitment to our mission and to support the patients and families and advance the research for Dessh. Many of them are here today, and I don't know if everyone knows who's on the board, so I want to mention everyone by name. We have Joseph Picarillo, Patty Cardona, Colleen Tosti, Nasheen Wasim, Amy Mitchell, Melissa Sidebottom, Carter Smith, and Susan Ford. And those who couldn't be here in person, Amanda Murphy, Tara Moore, and our UK liaison, Claire Studley. Thank you guys for your service. Okay, a few items before we get to the good stuff. We're on a tight schedule today, so the format of our agenda in most cases will be a presentation followed by audience Q&A. I'm going to be watching the clock. We collected your questions in advance, and we shared them with the presenters to factor into their presentations. I'll also be asking additional questions that were sent in advance from our virtual community who is joining us via Zoom right now. There will be a break around 10:30. Feel free to check in on your child at this time if they're upstairs. I want to let everybody know the presentations will be posted online at deshclinic.com early next week. So we don't have printed here, but you'll be able to access them shortly. And then a recording of this conference is also happening, not via Zoom, but via our videographer back there, and that'll be made available once it's made available to me. So I ask for a little bit of patience on that. All right, now we're really on to the good stuff. So I'd like to begin with our first presentation with the man who needs no introduction, the big honcho here at WashU for our community, Dr. Marwan Shinawi.
Thank you, Caitlin. Okay. Thank you, Caitlin. And I really appreciate this introduction. And actually, I have a slide for acknowledgements and things like that. I'll leave this to the end. Just because of time limitation, I would start with the presentation. So the main aim of this presentation actually to go over the clinical findings of related to Dessh syndrome. Most of the information I already shared with you, although actually I have additional data from the clinic from last year. Okay, so we'll talk about the name of this condition, whether this is going to change in the future or not, who decides the name of genetic syndromes, and things like that. All right. So Dessh Shinawi actually was first described in 2015. At that time, we described the condition in 6 patients that have been seen either here or in other institutions. The whole story actually started with 2 siblings that initially seen in 2014. They came to me with ADHD, evaluation of ADHD, intellectual disability, and some facial differences. My thought initially that they inherited the condition maybe from their parents. The assumption initially that this was actually what we call an autosomal recessive condition where parents are carriers and they pass actually the mutation to their kids. But I was surprised at the time with the results that I received with the exome sequencing. So fortunately at the time in 2012, 2013, we started doing the exome sequencing and we received these results of a candidate gene in the WAC gene. I knew nothing about this gene, and I started actually communicating with other physicians, other researchers, and through a system that we call Gene Matcher, I was connected with other physicians who actually have patients with mutation in the same gene. And this is the story started there. They started sharing with me clinical findings, pictures, and immediately I recognized the similarity between these patients. And we started collecting data about neurological findings and behavioral difficulties, and the pattern came to what later became known as the Dessh syndrome. So many clinical findings are obviously delayed milestones, later in life intellectual disability, decreased muscle tone, and other neurological findings, behavioral difficulties. I'll elaborate on these things, so no worries, this is just the introduction. GI abnormalities related to constipation, acid reflux, and eye abnormalities as well as facial differences. And this data actually from last year, I collected this data from last year. You can see actually the frequency of the clinical findings. I don't see very clearly there, but I'm sure that delayed milestones, gross motor delay, fine motor delay was found in 100% of patients. Speech delay 100%, and facial differences also very common. Found almost in every child. And we'll talk about this, what is the significance, if any, for these things. Behavioral abnormalities actually are found in more than 90%, followed by hypotonia, sleep abnormalities, and gastrointestinal problems in about 77%. Ophthalmological findings in about 2/3 of the patients, brain MRI abnormalities 53%, and seizures 47%. You would ask, the seizures, initially I didn't recognize this as a part of the genetic syndrome, but over time I started realizing that more and more kids exhibit some kind of seizure. Fortunately, these are milder seizures that can be controlled with a single medication, and in many cases it would resolve over time. I think it's a kind of bias here in the cohort that we had last year. This can be a kind of selection bias because those who are mostly affected, they wanted really to see us in the clinic to get a little bit more evaluation. With the larger set of data that I have, which is about 95 patients, the frequency of seizures way lower. It's somewhere between 20 to 22%. So how common actually Dessh syndrome? It's unknown at this time, but as you noticed, it's considered as an ultra-rare condition. The definition of ultra-rare, this is really below 200,000. Any condition below 200,000 worldwide, it's considered ultra-rare. So under this definition, obviously, almost every genetic condition would fit. But I was surprised, to go from 6 patients to quickly go to, my estimation now, at least there are around 200 patients that either documented or through my communication through emails with other providers, with other professionals. This is my estimation. 42 of those cases are well documented in the literature. As I mentioned to you, we are analyzing the data now of about somewhere between 92 to 95 patients, which is a large cohort. I'm going to share some of the data that we already collected. But we anticipate actually more and more cases to be discovered. I mentioned to many of you, this is a good thing. I see this as a good a trend, because the more cases we diagnose, the higher the interest, and many researchers will become interested in this condition. Even if we think about interventions, it's way easier to convince pharmaceutical companies to invest in a condition which is not really extremely rare. If you have hundreds of patients, then you definitely have the case to present for them that we want really to pursue some kind of intervention. And this is regarding the diagnostic, how we make a diagnosis. So usually the diagnosis is made with, it's difficult to make a clinical diagnosis, and definitely except for those who are heavily involved in and they have seen many patients with Dessh syndrome, it's difficult for them just based on facial differences and the pattern of the clinical findings to make a clinical diagnosis. And the most common scenario to make this diagnosis now, this is what we call with the exome or whole genome sequencing. And the data from last year, 13 out of the 15 patients, actually this way was the diagnosis made. But more and more insurance, if insurance is not really approving this kind of testing because of cost and the other considerations, we have different panels. Unfortunately, the WACGN was included in many of these panels of intellectual disability, seizures, more recently autism. So all of these definitely will increase the yield. One patient was diagnosed with a chromosomal microarray. This is to detect microdeletion, and I have a slide actually about that. But these are the minority of patients. So what is the clinical course? You would ask how we can make this diagnosis. So many of you most likely remember when your child was born with this condition, nothing was really unusual when they are born. Pregnancy went well, delivery without any complication, and this is also based on the data we have. Birth weight, birth length, everything really was completely fine. until you get to the point of expectation of acquiring more milestones, either sitting and things like that. So this is about the time we start noticing some unusual things. And it's rare actually to make a diagnosis below the age of 1 year, because usually you go to the primary care physician, to the pediatrician, let's wait a little bit, maybe this is just a normal pattern with a slight delay in milestones, which I understand definitely, but this is the usual pattern, delayed milestones, but also there can be some hints there. For instance, acid reflux and feeding difficulties can be initial signs during the first few months of life or a few weeks of life. And then constipation can be actually an early presentation. Later on, maybe they will be seen by an ophthalmologist for strabismus or crossing eyes, abnormal eye movements. We did notice that many patients exhibit stuffy nose and runny nose more often than kids without this condition due to recurrent respiratory infection, which is really a very important field maybe to research, to study in the future, the immune regulation. There are kids who are having immune deficiency, and there are a few kids receiving actually IVIG. This is kind of immunoglobulins that are deficient in their body and they need that. I'm aware also of few cases with short stature and due to growth hormone deficiency and also low blood sugar, which can be related directly to growth hormone deficiency, but we are trying also to investigate this issue, can be unrelated to that as well. When they get older, the picture would be more obvious. So parents would notice in more obvious way the delayed milestones, the gross motor delay, which is part of that is related to the decreased muscle tone. And usually the age of walking somewhere between 20 to 30 months of age. Fine motor skills also are relatively common, although usually these are not really very essential in early 2 years. They became more obvious later on. Buttons, zippers, handwriting, shoelaces, and things like that. Language acquisition can be significantly delayed. There are usually the average to start saying single words around 20 months of age. Obviously, this is the average. There is a range. And the sentences, many kids actually need more time, 3 to 4 years of age. Potty training is usually delayed until maybe 4 years of age. Later in life, cognitive disabilities become more significant in the sense that we're able to measure the cognitive ability, and we have definition of based on IQ testing, for instance, based on the data we collected from last year. So the range is really between mild to moderate intellectual disability. I do believe that they are not performing well due to part of that hyperactivity, definitely some behavioral difficulties. I do believe that kids with this condition actually have little bit higher level of cognitive ability than these tests would show. And this is important because if you treat the hyperactivity, if you correctly treat ADHD, I do believe that maybe you can get better outcome in that regard. But this is the data we collected, the average IQ 66 and the range between 50. And it's not unusual, actually. There are a few kids, even in this clinic, we saw with normal range IQ in the normal range. And then behavioral difficulties become even more obvious. And if you ask all families, actually, what is the item number one that you want really to manage and treat in your child, they would tell you behavioral difficulties is really the most important for them. There are some hints in first year of life, but again, this is kind of retrospective analysis of data that many kids are a little bit fussy. They kind of crying a lot and things like that. Later on, I don't know if this is manifestation of something, but later on, other findings include ADHD, some autistic features, anxiety, OCD tendencies, and aggressive behaviors, biting, hitting, and sleep abnormalities can be difficult for them, including falling asleep, awakening, and there are also increased risk of sleep apnea. And this is the data from last year. So surprisingly, the OCD was the number one, actually, the most common one. ADHD is the second. Anxiety is very common, more than half of the patients. Aggressive behavior and what we call self-injurious behaviors. Autism and autistic trait in 40%, and impulsivity as well. Neurological findings, I already discussed the hypotonia, decreased the muscle tone, delayed milestones, behavioral difficulties, but seizures, as I mentioned before, also can occur. This is the citation note I mentioned to you. I think it's an overestimation of the actual number for seizure. There is some indication, we are trying to study this, that if you have seizure, there is a higher chance of having more cognitive delays. I don't know how, and I'm glad that our neurologist here, I'm sure maybe they can address this correlation between seizures and cognitive abilities. Brain neuroimaging can be abnormal in those kids. Based on the data from last year, 7 out of the 13 who had actually brain imaging had some abnormality. These are non-specific, which means that if I see the MRI, I wouldn't tell that this is really for a patient with Dessh syndrome. There is some indication also that patients with epilepsy are more likely to have abnormal MRI findings, which may suggest maybe these abnormal MRI findings are really important for the seizure. The last item from the clinical standpoint, this is really the facial differences that I mentioned to you. I explained to all families these are more cosmetic issues. They are important for me as a medical geneticist, but in reality, they don't have really clinical significance in the functionality of these organs. So we describe, the shape of the forehead, that this is really broad. They usually have a squared face and deep-set eyes. And in my opinion, the eyes are the most characteristic. Actually, I can show data. You did notice also increased hirsutism. This is excessive hair. A flat nasal bridge, the wide mouth. This can be also characteristic. And hand and foot anomalies. And these pictures actually from last year. Some of you can see your child here. There are some similarities. I mean, to me, I can see lots of similarities. I mean, this is what we are trying to train our residents and fellows how to recognize these, what we call dysmorphic features. But again, these are more cosmetic issues. This is actually from our initial cohort. These are the two siblings that initially I've seen in the clinic that led to the discovery of this condition. And these are the foot anomaly. I most likely notice some of these, especially the great toe. Sometimes we have what we call a fusion between the second and the third toe here. Sometimes overriding toes. More and more, which I didn't really know before last year or 2 years ago, started noticing the dental anomalies. And this is the advantage of having many kids in the same place. You start so can be discoloration of the teeth, but also the arrangement of the teeth can be different. And the excessive hair, you can recognize this here. and sometimes they have thick eyebrows and what we call low anterior hairline. I don't have hair to show you what's normal, but sometimes you can have creases behind the ears or pits actually that are located in the. And these are actually, this is really very, for me, it's important slide from last year. I collected this data from last year. So the most characteristic, as I mentioned to you, actually, these are the forehead and things like that. The deep set eye, this is really the most important. And the thick eyebrows, this is the number 2. Although other findings also can be as important. I found also the mouth to be very typical for this condition. Less, actually, the ears are not really diagnostic for this condition. So these are the frequencies in the ears. These are the frequencies in the mouth, and these are in the nose. The nose can be really unique for those kids as well. So what's the etiology of this condition? As I mentioned to you, this is a mutation or pathogenic variant. This is the new terminology that we use for mutation. We try to avoid using mutation in a gene that's called the WAC. This is the long name, WW domain containing. So instead of saying this every time, so either WAC or WAC, I like that, WAC. So the great majority of patients, they have a point mutation. This is a changing one amino acid to either stop codon or frame shift and things like that. But the ultimate outcome is almost the same. This is disruption of the function of the one gene. So there are 2 copies in our body, and one of them is not working well. The outcome is really, and I mentioned for a few of you, that this is really what we call a dosage-sensitive gene, which means that 50% of the amount of this gene is not sufficient, especially for it looks like for the function of the brain. Maybe it's sufficient for other organs. This is the reason that we don't see really great, lots of manifestation there, but it looks like this is really very critical gene from the dosage standpoint. There are other genes that are very tolerant actually for even decline in the amount to 20% or even 5%. Our body would handle that. But for this gene, 50% is not really sufficient. There are a few kids. I'm aware in our cohort, the larger cohort, there are 9 patients actually with the deletion. This is missing the WAC gene. These are not point mutation. So what is missing on a chromosome 10 can actually be from 1 megabase to 10 megabase. So these are the measurements that we use to measure the length of the chromosomes. So why we are including actually this 10p deletion as part of this genetic syndrome? Because most of the kids, they have lots of similarities to other kids with the point mutation. It looks like the WAC gene is the most critical gene, although other genes are deleted in that interval, but WAC is really the most significant there. The larger the deletion, the more clinical manifestations are there. And this was an evidence for us that the mechanism of this disease is by what we call haploinsufficiency, which means this is loss of function, because if you're missing half of the dose of this protein, definitely you get all of the clinical manifestation. Very common question for many of you regarding, is there any correlation? Why we have these variations, even among this small cohort of patients that we see in the clinic? Why we have this variation? Why this individual has a seizure, the other individual have more behavioral difficulties? Even the facial features can be different. I don't have definitive answer at this point, but we are trying to study the following things. So the type of the mutation can be relevant, whether this is a deletion or a frame shift or stop codon and things like that. I think the location even more important in the gene. Initially, in our initial article, we mentioned that mutations in the second half of the protein, especially toward the end of the protein, are less severe. I think we have some data supporting this, even with a larger cohort of in our study. And there can be different isoforms, different forms of the protein. Some of these can be missing segments of the protein itself. And if the mutation in that missing segment, so this isoform wouldn't be affected. And always we say that we cannot think about the WAC gene as working in isolation. This is really interacting with many other genes that can have also other variants that can affect actually the function of the protein itself, the WAC. We call these genetic modifiers, and I'm wondering whether there are also environmental modifiers. One of them, no doubt, and this is really one of the recommendations, stimulation early in life and therapies and things like that would change the outcome regardless. This is the time that we have plasticity of the brain. This is the time to invest in your child to change the outcome in the future. So this is what I mentioned before. For instance, isoform 2 here, where is it? Isoform 2 here is missing the first 47 amino acid. And this is really very common isoform in the cerebellum. And if the mutation is located here, it's not that this isoform is not going to be affected. So maybe this is one explanation, for instance, why the location of the mutation is really important. Inheritance, so this is what we call autosomal dominant condition. All the kids that most of the kids that we follow, they don't have affected parent. Okay, so the mutations are what we call brand new mutations. If you see the report, they would mention de novo mutation. De novo means that these are brand new that occurred either during the formation of the egg or the sperm, or alternatively, very early stages of the embryo. So they are not found in your body. You didn't pass this. They occurred during the formation of the egg or the sperm. However, there are a few recurrence in the same family. I'm aware of 4 or 5 families where one child, they didn't expect to have another child with this condition because parents were negative with the genetic testing. So, and they still had another child with the same condition, including the family that I have initially seen here, the 2 siblings. We did the testing on mom and dad, and it came back negative. So the assumption that this is what we call germline mosaicism, where either mom or dad actually have the mutation in their germline, in the eggs, in the case of female, or in the sperm. So this is unusual because usually we counsel families for other similar condition, autosomal dominant condition of 1%. But based on that, I think it's more, I don't know why, what's unique with the WAC gene. I think this is important from the counseling standpoint. More than that, we are following a few families where there are generations, 3, even 4 generations, one family, 4 generations who pass the mutation from one generation to the next. But these are the minority of cases. The great majority of cases, this is not really inherited. And for the 10p deletion, I'm not aware of any case that was inherited from a parent. But nevertheless, we need to do genetic testing on mom and dad always, because to exclude the possibility that they are carriers. Sometimes they have really low percentage in their blood of the mutation. But this is important actually from the counseling standpoint. And for the chromosomes, usually we recommend to test mom and dad to rule out what we call unusual chromosomal rearrangements in their chromosomes. They're not affected, we know that, but sometimes there are some rearrangement that can lead to that. So the last few slides is about the vision of what we expect in the future. Just a few things about the naming, who actually called this Dessh or the WAC related. So usually OMM, this is the online inheritance in man. This is an online free funded by the NIH, would call actually conditions. So there can be different ways to do that. One way is really to take the name of the gene and to call this WAC-related disorder, which is completely fine. But other time they decide based on to recognize those physicians who first described that condition. Other times there is a condition that is being studied here at WashU. It's called Mitchell syndrome. This is based on the name of the first patient actually who was described with that. So there is some sensitivity here regarding calling names of, even if you describe this to be the first, this wouldn't say that you have ownership for that condition, which I definitely understand this argument. Sometimes for families, it's much easier to say Dessh syndrome instead of saying WAC-related disorder. So this can be a consideration. And there are many cases where one gene actually can cause many different conditions, and this can be confusing. We're not aware this is actually true for the WAC gene, but this is definitely true for many other genes. This can cause DISH, this can cause many other conditions, so it's difficult to say just the WAC. So nevertheless, I mean, if you go to the OMM, I mean, you see this as Descento-Chenaui syndrome, DISH syndrome. They did include the chromosome 10p under this, which I agree to some extent, but not for the larger deletion. If we have time, we can really discuss this issue more. So what's next? Study larger cohort of patients. This is the most essential, and we're doing this. Dr. Amanda Smith, one of a PhD, she was working here in the field of leukemia. She became interested in this condition because the somatic mutation in the WAC gene actually it can be associated with different kinds of cancer, leukemia, and things like that. She became interested in that, and we are working together to finalize the data on about 95 patients. The aim is really to issue kind of guidelines for families, for providers, medical geneticists, if they make a diagnosis, what to do next. We need to study adult patients. We don't know the natural history of this condition. There is a great need, and this is one of the biggest concerns for many families, that what to expect in the future. My child gonna finish high school, gonna go to college, gonna be independent, which kind of life, gonna get married, and things like that. So we need to study this more, and to study the effect of early therapeutic interventions. This is obviously not enough to make a diagnosis. We need really to treat. This is the aim of medicine, to treat, not to just make a diagnosis. This is really a survey of the cohort of patients that we follow regarding the medication they use. 2/3 of patients taking medication, 1/3 do not take medication, and this is the medication for constipation is the most commonly used. Allergy, asthma medication is very common. Stimulants for ADHD, very common. Anti-epileptic, for sleep, Motrin, not Motrin, come on. Yes, melatonin. And for depression, for anxiety, psychosis, and acid for acid reflux. So what kind of data we are trying from large cohorts? So look at the right, you can see actually the distribution. This is what we call normal distribution of the BMI. This is the ratio between weight and height, right? And you have in the middle, the moderate, obesity and things like that, the BMI of 25, it's not obese, and you have this kind of distribution. Look at the distribution in our cohort. There is significant skewing so this is a greater than 90% percentile of the BMI. Most of the patients toward above the 60th, the 70th percentile, which is really very important to study in the future. Uh, So we need, obviously, you're going to hear a little bit more about that, researching that gene, the function of that gene, how this is related in model organisms and in vitro system, and utilization of available resources and opportunities in science to advance efforts toward the long-term goal to find a cure for Dessh syndrome, and what's the future of the Dessh clinic. Hoping to maintain this every year. And Caitlin can tell you how difficult this can be but we are fortunate to have the support, at least at this till this time, of WashU and St. Louis Children's Hospital. So this is kind of my vision for the future. We don't have time really to go over that. If we have time, we can definitely address this issue. And this is really important slide. So this was really a major effort. We started actually planning 2 months after the first clinic, and we are very thankful for we are very thankful for the Dessh Foundation. This is really wonderful illustration, the collaboration between the family support and the clinician. This is the way it should be. This is the way we only advance our cause to find a treatment for this condition. Patients and their families. I don't really want to mention names now because of short of time, and Division of Genetics and Genomic Medicine. Caitlin already mentioned Dr. Dixon. She really gave us really great support. Dr. Healy helped me with examining patients, and the other individuals mentioned there. Neurology, we are very thankful for them volunteering their time. Pediatric ophthalmology, you saw Dr. Reynolds, she really became expertise in this condition from the ophthalmological standpoint, and obviously the psychological services and the PCRU team. This is where the unit actually, this is the research unit that all right, thank you.
Thank you, Dr. Shinawi. So we went over a lot in that short amount of time, and I hope that a lot of the questions were answered that we submitted in advance, but we do have about 10 minutes for Q&A with Dr. Shinawi. If you guys have any questions, I just ask that you speak into the mic so the Zoom participants can hear you.
What's the incidence of orthopedic differences in the Dessh patients?
I don't have exact numbers, and the main reason...
You can take that off if you want.
Yeah, can you hear me? Yeah. I don't have exact numbers, but this is really very important question. The reason for that, initially I didn't recognize this as one of the features, but obviously when I started seeing more patients in the clinic, families also alerted me to these findings. We started scoring these. So I think the data is not really complete, even if we say 10, 20%, this is what my estimation. I think it's inaccurate. I think it's way more common. And I started asking about joint abnormalities and things like that, examining feet, examining other part of the skeleton. This is really important.
With the germline, should we be testing our other children?
No, yeah, very good question. No, there is no reason actually to test other kids. It's gonna be relevant just for the parents. If they are planning a second or the third child, this is gonna be relevant for them. But the question how you can test that, it's difficult. There are no clinical labs who can test sperms and eggs for that. So one option would be obviously to do prenatal testing, or to consider IVF to do the testing and then decide which embryos to use to continue the pregnancy. There are many ethical issues behind that. Definitely one factor can be what are your beliefs and so usually we discuss these issues with many families. and based on your what you believe, because you need to ask yourself if you do the prenatal testing, what you're gonna do with this information. Would you consider termination of pregnancy, for instance? This is a condition which is not associated with the mortality, high mortality, and with severe congenital anomalies and things like that. So there are lots of ethical issues. Somehow there is this impression that in genetics we take decisions for them, but this is not true. Actually, our job is really to try to provide the best, information, and the counseling should be knowledge directed. To be honest with families, what are the percentage of recurrence? If we have such data, to discuss with them the different options of a prenatal testing, and they will take the decision based on this discussion.
Hello, doctor. Do we know if girls or boys who can have more severe symptoms? Girls or boys?
Oh, it's a good question. So we are trying really to analyze the data. I don't have such information. A general impression, ADHD is more common among boys somehow. But again, it's not really final analysis, but we are trying to investigate that. Very good question. This is one thing that we are trying to investigate, whether there is a change also in age over time, whether there can be different manifestation. But this is really a very good question. Thank you. Yeah, this is even more important question, because in general, autism is known to be more associated with with the male in males, more common in males. Actually, if you take 100 kids with what we call idiopathic autism, the ratio between males and females is 4:1. So the exception for that, actually, when you get to the syndromic autism, where the ratio would be closer, actually 1:1 between males and females. I didn't get the impression that autism is more common in our cohort, at least, which is 95, more common in males than females. This is not the case, which is consistent with the previous data with the syndromic autism. The ratio is almost equal. Yep.
Dr. Shanawi, I think anecdotally, people report that a lot of their patients have seizures that occur later in development and aren't apparent early on, but maybe at 4 years old, maybe even at 15 years old. Is there any understanding of why that may be the case of a delayed onset of seizures in a child's life?
It's a very good question, because, the assumption you are born actually with this condition, and the deficiency of this protein is present there. So what are the triggers that can cause, the tendency of having epilepsy and things like that? And I think neurology would be very helpful in that regard. Do you want to comment now or leave it? Thank you so much.
So in many neurodevelopmental conditions, a lot of epilepsy is going to occur in the early infantile, early childhood period, and so there'll be outliers where it may occur later in adolescence or in teenage years. There's not a good reason for that, just because there's so much variability and heterogeneity in these conditions. Hormones may have something to do with it, but I tend to see when folks develop epilepsy, it's more early on than not. That partially answers the question. That's a long way of saying I don't know.
Yeah, no, these are really very good questions that we need to study. And
Has there been any information, I guess, I don't know if through this clinic or just your research, of the parents of these children having any of the screening that they had during prenatal? Like, for instance, I had like the triple screen and whatever was recommended to me at the time that showed abnormalities.
No.
Okay.
I mean, as far, we do get information. And usually, if you notice, I mean, this is really very extensive. Family history and things like that. We try to gather as much information. You're right. I mean, we don't do the physical exam. We don't really get medical records and things like that. Based on the data that we have, if they are not affected with this condition, if they are not a carrier for the mutation, we don't have any evidence that they are.
I was just wondering, like, during their pregnancy with the child who is affected with the condition, if there was anything that came back.
Nothing.
Okay.
We
Okay.
asked this question. Nothing.
Okay.
Yeah, we asked about pregnancy course. We asked about regarding movements, fetal movements, and things like that. So again, I mean, the limitation of retrospective studies, this is based on memory and things like that, and the memory bias. You can imagine how difficult if you start asking about did you feel enough fetal movement during pregnancy. But we did ask these questions. We did ask about exposures during pregnancy. We did ask routinely, we asked about smoking, alcohol, other drugs, other medications, and things like that. These are routine questions that are really well covered in ours, so we don't have any indication that something is unusual.
Have you heard anything about regression of any type?
Thank you. It's a tricky question. Yes, so this is really very good question, and this is really something to investigate, which definitely with the animal models that we have, I think they're going to be very useful for us. So there are some indication when they start seizing, there's some degree of regression. And maybe neurology can comment also on that when they discuss this issue. So there is some indication in that regard. The biggest question, and I'm trying really to understand that when they get older, are there any course of neurodegeneration or something like that? At least based on the limited data of adults that we have, there is no such indication. I did mention to many of you, we're following a patient is now 39 years of age who developed actually Parkinson's disease at the age of 35. So you would ask yourself whether this is just a coincidence and what should we use this information to counsel families and things like that. So this is only one case that we're aware of, but definitely what I mentioned before regarding some regression after starting having seizures, which is very common, right? In neurology, sometimes you can have this kind of regression. But the biggest question, whether there is neurodegeneration and things like that, is unsolved. But we're watching this issue.
Thank you so much, Dr. Shinawi. Thank
so
you.
much.
So next up, we're going to shift gears a little bit into a panel format. We have 3 doctors here, an ophthalmologist, a neurologist, and a psychiatrist who will briefly talk about their specialties and Dessh, and then it will be a full panel discussion, so you guys can ask targeted questions to these specialists. I'd ask you all specialists to come on up front.
So feel free to keep getting coffee and breakfast and get up and move around while I talk here. So, but I'll just kind of talk briefly here about some ocular manifestations of Dessh. This is my second year being here, and I will say I think, doing this for the second time, I actually think we kind of learned a lot more, so thank you all for being here. I don't have any conflicts of interest. So you all are very familiar with Dessh syndrome. It's a variable presentation. And I'll let some of the others talk about some of these things, but you are all very familiar. But I'm here to talk about the eye abnormalities. So Dessh is secondary to a mutation in the WAC gene, and this gene is expressed in adult and fetal tissue, and it's expressed in the eye, which is why I'm here today. So there's some commonly described eye findings. First, there's kind of some appearance findings. So if you look at the eyelids and orbit, so the orbit are the bones that kind of surround the eye. So kids pretty classically have kind of deep set eyes, which you can measure like this, and maybe at some point we'll do this, but it's a little bit uncomfortable, so we didn't do this. But there's no implications from an eye health standpoint. So hypertelorism is increased distance between the orbits. Some kids have this. Again, no problems with the health of the eyes, so not a big deal from our standpoint. Ptosis, or droopy eyelids, so it can be caused by weakness in the muscles, nerves, or tendons that lift the eyelid. It seems like maybe it's a muscle problem in kids with Dessh, but if the ptosis is blocking the vision, it can be fixed with surgery, and we do that just to help make sure that visual development's normal. Once kids get a little bit older, usually after the age of 9, you have to worry a lot less about losing vision. So at that point, you don't necessarily have to fix the ptosis. But and then prominent brow is quite common, and again, it doesn't affect the health of the eye. Strabismus is another more common problem, and it's any misalignment of the eyes. We don't know what causes it in general or in Dessh, but so you can have an eye that turns in or an eye that goes out. So horizontal strabismus, esotropia, the eyes go in, exotropia, the eyes go out. Or you can have vertical strabismus with one eye higher, one eye lower. And again, we don't quite know what causes it. Fortunately, you can manage it pretty easily. It depends, so whether or not you need to manage strabismus depends on control. So if it's infrequent, you don't necessarily even have to do anything about it. But if it's more frequent, you start worrying about visual acuity and depth perception. And then you probably want to treat it with glasses, patching for kids who have one eye that's stronger than the other. And then the last option, surgery. And fortunately, the surgery is outpatient, pretty minimally involved. And then another more common finding, so myopia or nearsightedness and astigmatism. So these can be corrected with glasses, and the kids still get 20/20 vision. And myopia it can be onset at a younger age, but it can be one of those things that doesn't come around until kind of like middle school age, and that's common for everyone. If anyone had like significant myopia progression, it was changing every year, there is an eye drop called atropine that can help stop the myopia progression. Although with kids, sometimes, drops, the cure is almost worse than the disease. So it's one of those things to think about, but, and that's kind of a newer treatment and everyone's excited about it. Astigmatism is, so myopia or nearsightedness has to do with the length of the eye. Astigmatism is when the eyeball is shaped more like a football than a basketball, and it has to do with the kind of the cornea and how it's curved. But again, it can just be fixed with glasses. I think one thing that kind of did come up a few times, so if kids really have a hard time seeing, if they're having a hard time seeing and they need glasses but they won't wear them, we do refractive surgery here, and some of the kids, as they get into adulthood, if they still didn't want to wear their glasses, you can fix that with refractive surgery, but just another one of those things that might make life easier. And then lastly, something that kind of I feel like came up more this year is cortical visual impairment. So cortical visual impairment is actually thought to be the leading cause of childhood blindness now. So it's pretty poorly understood, particularly I would say by ophthalmologists, as a matter of fact. So basically what cortical blindness is that the eyeballs themselves are perfect, or they don't, or the level of vision is not consistent with what you see in the eye. And so it's essentially the eyes are good, but the visual pathway or the brain is affected. And so it can manifest in different ways. So it can be a processing thing. So kids can see okay, but then they just don't process what they see. Or it can be, they can have decreased vision because their occipital lobe is affected. So I kind of went into this a little bit, but for the purposes of time. So the way that we treat this is we work really well with therapists. Here we have an occupational therapist who specializes in cortical visual impairment and in low vision kids. And I actually think the teachers in the community, the teachers for the visually impaired, are very good at actually diagnosing this and bringing it to our attention. So if you have concerns about those would be the people I would reach out to, the occupational therapists at school, the teachers for the visually impaired. Usually you can include that in your meetings with the teachers every year. And again, this is one of those things that the kids tend to do quite well if they're having this. So it's not necessarily something, that we have that we can fix, but the kids usually compensate very well. So if you get them services, they can compensate really, really well. So Anna is our specialist here at WashU. And so this is my email. If you guys have any questions, well, happy to take them there, but once you leave, happy to take questions at any point. And thanks everyone for being here. I feel like it's been very helpful. So.
Thank you, Dr. Reynolds. So I'd like to introduce Dr. Glazer to all of you today. He is a psychiatrist and child psychologist, just child psychiatrist. Pediatrician, adult psychiatrist, child adolescent psychiatry. 3 in 1 we got here for everybody today.
But I just have one wife.
Oh, good. That's good. Only one wife. How many kids?
4 kids.
4 kids. Congratulations.
And I got 2 degrees, MD and a PhD. So.
Wow.
All right.
Here we go. These are you. I'll turn it over to you.
So yeah, I've been in the field of treating developmental disorders, autism, ADHD for 25 years. And I'm sure along the way I've treated some Dessh kids without even knowing that they were, just based on the facial features. But all I can say is from a psychiatric standpoint, it's tricky. It's very tricky. And even though we know they have this common time, there's 10,000 other genes that affect our behavior and our family structure, and the fact that you as parents probably have your own set of psychiatric issues. So it makes it well, maybe 1 or 2 of you. Your spouse. All right. So, but it makes it very hard to have easy answers. But we do have some template that I want to give you. Here are the most common behavioral issues I've seen in reviewing the literature and my own patients. And so I'll touch a little bit on each one of these. And by the way, I forgot to put in the ADHD stands for Attention Deficit Hyperactivity Disorder, and DMD is kind of like the new version of child bipolar. It's disruptive mood dysregulation disorder. And we love it because it doesn't mean your child's going to be bipolar as an adult. It just means they have really tricky mood swings. All right, I did peruse the literature to see if I could find any theory for why the brain is this way. And the closest one I got was this recent paper showing that this WAC protein does disrupt GABAergic neurons. Is that a fairly common finding now, Dr. Shinawi, or is that still early on? Okay. Yeah, so I would say really what that makes me think of is that really we have a hyperglutamatergic state. That's a hard word to say. We have too much glutamine. See, glutamine and GABA kind of balance each other in the brain, and without a good GABA tone, you have too much glutamate, and that's going to lead not only to seizures, but a lot of behavioral troubles. And yeah, that's unproven. So just a couple things that I wanted to bring up. You know, if aggression is a trouble, ABA is probably like our gold standard. Does it work for everyone? No, it's a very time-intensive, expensive therapy that not everyone can get to. But if it helps you avoid medications, I think it's worth its weight in gold. And we have some very good people here at WashU that are experts at this, and other people in the community that are very good in St. Louis. But not every community is going to have this. So the other well-proven theory is PCIT, or parent-child interaction therapy. This is perhaps a little more translatable to the home because it teaches you how to interact with your child in a way that reduces some of their behaviors Once again, especially good for aggression. It does require your child or adult to have more communication capacity than ABA, so this is not going to be right for everyone. And it takes parental cooperation. So you've got to say, well, maybe I am part of the problem, even though I am a perfect parent. I want to become a better parent. So I just wanted to give a list of some medicines that you could take to your doctor who's ever prescribes psychiatry medicines. We do have an autism center clinic here at WashU. There's several others around Missouri, and hopefully every state has some child psychiatrists, but there is a great shortage of child psychiatrists, so it's very hard to not only find one, but one that you trust and one that also has experience with developmental disorders. Those are extremely rare. So we do train 5 new child psychiatrists a year here at WashU, so that's one of my goals, is to get more experienced child psychiatrists out there. These medicines are very hard hitters. They have a lot of side effects, so I tend to avoid these if I can. And then you'll see some others below that we use besides the risperidones and the Abilifys of the world. There's also naltrexone, lithium, and amantadine. So we know that if you have too much glutamate, you also have a high risk for anxiety. And why is that? Well, the kids that can describe it tell me that their brain is racing. They can't stop these thoughts, and it's glutamate going over and over again and telling them, you've got to do this. Some of them become obsessive about their anxieties too, and if they can't get and complete that behavior, they get very anxious. Some, it's because they expect something to be a certain way, and if it doesn't happen that way, they get very upset. And then others, just seem to have mood swings based on this because they'll have triggers, whether it's sensory triggers or behavioral triggers, and that leads to irritability and sometimes huge blow-ups. So sometimes we try the medicines we use for anxiety and depression first, and these are listed here. Sometimes we use a little off-label ones, such as the Cymbalta, Effexor, and Boost Bar. Attention can be a trouble, and especially impulsivity. And once again, it's that drive that once they get something in their mind, they can't get it out of their mind. They're driven to do it, even if it's dysfunctional or drives you crazy. And so these are some of the medicines. The stimulants sometimes do help, but more often than not, if you have a hyperglutamatergic state, it's going to cause you to be more anxious and basically hyper-focus them on their restrictive interests and then backfire. So sometimes we have to do these non-stimulant medicines for the impulsivity and ADHD. The ones that I've found second line that has been amazing for a few of my patients has been memantine or Namenda, which is traditionally an Alzheimer's medicine, but it works through the glutamate system and has really helped some to calm down and help their focus some. So here are the anti-seizure meds, and I use these, especially if all those other medicines fail. These are kind of my go-to medicines, and they seem to help every single behavior that you would see in Dessh. And so these have been, I discovered these on my own kind of 20 years ago, but as the field's gone along, we are starting to have some scientific evidence for these. And of course, neurologists are already very comfortable using these. The top 3 other ones I use the most because I feel they have the least amount of side effects for my patients, but I have used the bottom 3 as well. And I know there's neurologists in the room, but I do not like what's that one? Levetiracetam, Keppra. That always seems to make behavior worse. So, see, I heard an ONG in there. All right. And then finally, the best medicines I think for your patients, which are the hardest to get in today's society, are these things: structure, sameness, predictability, keeping your promises, simplicity, family focus, and consistent discipline. So if you can work on yourself and your family and get some of these in your family, get the screens out of your lives and their lives, just a lot of really common things, and you'll find that these also do help. we live in a chaotic world that causes all of us anxiety. So I'll leave with that message, and hopefully they'll have access to all these slides so they can take them to their doctors. All right, great. Thank you.
Thank you, Dr. Glazer. I'd like to invite Dr. Sheil Pathak, neurologist, to come and speak with us next. He worked with Judy Weisenberg, who many of us saw yesterday, on preparing some of these slides for us today. So thank you.
Thank you. All right. Click oh, there we go. All right, perfect. So yeah, once again, I am Sheil Pathak. I'm one of the pediatric neurologists here at WashU, and I am speaking here today in place of Dr. Weisenberg, who many of you guys met. She had familial obligations this morning, and so I had the opportunity to speak with you all and learn a little bit about you guys and Dessh syndrome. And so I do not have any financial conflicts of interest or otherwise. Nobody pays me. And so you guys know quite a bit about Dessh Shinawi syndrome, but there are some specific neurologic manifestations which we already kind of went over a little bit, seizures and motor difficulties and developmental issues, but we can go into a little bit more detail now. And so these animations work. I think I got a little crazy with PowerPoint yesterday, so let's... Oh, it works perfect. And so hypotonia, or low muscle tone, everybody's kind of come across that term before. Not everybody knows what it means, and so I like to explain. So some people think, oh, hypotonia or low muscle tone means that you are weak. It doesn't mean that. Low muscle tone, I think of all muscles in your body of having a certain springiness, or if you have like a rubber band, it needs to be a certain tightness in order for it to work. If you're trying to shoot the rubber band at your friend or something, if it's too loose, it's not going to go anywhere. If it's too tight, you're going to have to use an excessive amount of strength in order to get it to go anywhere. Same thing with muscles. In order to do stuff with your muscles, they have to have a certain amount of tone to them. And if you have low muscle tone, you have to have more strength in order to do the things that you want to do. You have to have more coordination to do the things that you want to do. But if you have a typical amount of coordination or a typical amount of strength, oftentimes it's difficult to do just normal things, and so it can cause problems with feeding, posture, mobility. That's why you see sometimes children may walk later than others. We do tend to see that this gets better over time. How much better is variable. Obviously, we don't have the numbers, but for a number of other neurologic conditions that present with low muscle tone, that tends to improve over time. And it probably has to do a little bit with, you've had several years of doing more things and working your muscles, and so you can overcome some of that. We also think about why somebody might be having low muscle tone. And so when we think about your nervous system, you can have, and as a neurologist, we think about this all the time, where is the issue? You can have issues in your brain, your spinal cord, the connection between your spinal cord and the nerves themselves, the muscles, or even the connection between the nerves and the muscles. In Dessh syndrome, the thought is that the problem or the deficiency is in the brain, not necessarily at the muscle level. So there's not a problem with the muscles, there's not a problem with the nerves, it's more of an issue with the brain and the connections between parts of the brain. We know that the WAC protein is expressed heavily in the cerebellum, and if we think back to high school biology, we think, oh, cerebellum is very involved in motor and balance and things like that. It's also very important in cognition and language and attention and focus, as well as the motor stuff. And so I think that that's possibly a theory as to why folks have some of the difficulties that they do. And so I'm going to click forward. So Dr. Glazer already discussed ADHD and scholastic difficulties. There's some evidence that on neuropsychologic evaluations that I was able to review, there's difficulties with nonverbal memory tasks like remembering faces, shapes, colors, tastes, and things like that. and then attention and focus. And obviously, having ADHD, it's not only just the traditional attention and focus issue, it's also difficulty regulating your emotions. I think of, if your brain is like, the Walmart and all the workers are awesome, but the manager's out to lunch, that's kind of what ADHD is. And so we have difficulty controlling your emotions, controlling impulsive behaviors, and you can have frustration more easily than other folks when doing a task, so low frustration tolerance. Some folks have what we call apraxia. I think that goes along with the developmental delay, low muscle tone. And apraxia, in simple terms, I guess, is a problem with the connection between the brain and your muscles. And so every motor thing that you do, if I want to bend my arm or if I want to reach for this microphone or whatever I want to do, comes with, say, like a computer program in my brain that tells my muscles which ones to relax, which ones to contract, etc. And with apraxia, there's a problem with that system. And so the hardware might be okay, but the software basically telling your muscles to do what they're supposed to do is not working properly. And so it's not a problem with strength, it's a problem with just motor planning, basically. So someone might have the strength to, say, stand up tall, but doesn't have the motor skills to pedal a bicycle because it's a little bit more of a complex skill. That can result in difficulties with feeding, swallowing, and talking, because all those require a lot of coordination with muscles that many of us take for granted. So multi-step purposeful activities are often impaired. The next thing which we'll touch on, we already touched on it, is epilepsy and seizures. We'll talk about what that is, but several patients have been described who have various types of seizures, as well as various types of spells which are not seizures, and I think that's an important point that we'll get to as well. And there's been several patients with abnormalities in the structure of their brain that have been described as well. And one thing that's important to know here is that you can have difficulty, or you can have problems with the function of your brain that doesn't necessarily translate to a structural problem of the brain. And I equate that to, like, you're in an airplane and you're flying over a city and there's a robbery going on, but you can't see that everything looks beautiful, like mountains and whatnot, from the airplane. That's kind of the difference between structural problems in the brain that we can see with the technology that we have available today and stuff that we can only kind of diagnose clinically with ADHD questionnaires and observations and things like that. And so some terms that you guys might come across. So many children are diagnosed with global developmental delay. When we think about development, we think about a few different areas of development. Somebody can have delays in their gross motor skills. That's walking, sitting, rolling, kind of the big muscle group things. Fine motor skills is the next thing, manipulation of utensils, writing implements, pushing buttons, things like that. Language and speech, and then social and adaptive skills. Can you learn stuff? Do you like being with people? Those kind of things. If you have a delay compared to other children your age in at least two of those, that's called global developmental delay. And so that's a diagnosis that many kids may be given so that they can qualify for a variety of therapies. Periodically tracking that development is very important. Because if we go down to the very bottom of this, I guess I picked the wrong red because it's kind of hard to see, but development should be going forward. Every child has their own pace of development. Not everybody develops at the same rate, but it should be forward. You may have intermittent plateaus or you might have hiccups, but if you zoom out, things should be you should improve in your skills, you should learn new things all the time. If you're not, if you're going backwards, hey, we were speaking in sentences and suddenly we are not, that is a problem. That's not something that you can ever chalk up to, oh, this is, Dessh syndrome, or this is whatever syndrome, or this is autism. No, it's not. You have to look into that further if you have that type of fall off of skills. Sometimes you see fall-offs of skills that could be normal. Let's say at the beginning of the school year, oh my gosh, we have a new teacher. We don't like the teacher. We're not doing the stuff that we were doing last year when we had the teacher that we liked. Or there's a kid in the class that's bothering us, or whatever the thing might be. So environmental factors can play a role in these little regressions. And so our job as a neurologist to say, is this regression, is this developmental regression caused by an issue that's happening in the brain, or is it stuff that's going on outside in your world? And so that's why getting a really good story is super important. The next term that folks would come across is intellectual disability, and that's something that's measured by psychoeducational testing, neuropsychologic testing. There's a variety of testing that can identify this. And intellectual functions that has to do with someone's ability to solve problems, think in abstract terms, and then also has to do a little bit with their academics, as well as their adaptive functions, kind of their ability to function at age level compared to other kids who may have thought to be typical development. And once again, in that bad red, it should go forward, not backwards. And so how do we manage these different things? The first thing is, if you have ADHD, I know Dr. Glazer touched on this, ADHD or behaviors that are self-harm behaviors or aggressive behaviors, there's a variety of medications that can be used to treat these. The biggest thing to think about is that there's not one specific medication for any specific neurodevelopmental syndrome. We don't have that level of precision medicine here yet, but that's why we research all of these things so that we can have that level of precision medicine one day. There's ADHD medications, there's medications to reduce self-injurious behavior and aggression and anxiety, and my biggest thought is it's trial and error, it's educated trial and error. Any medication that you start, you can stop if it doesn't work. You're not committed to something forever. I know a lot of people, oh, we don't want to start this medication. It will turn them into a zombie. Well, guess what? Don't take it anymore, and then you won't have that. And so it's always worth trying. And so if the potential benefit of a medication, hey, this is really going to help us live and have a happier day and have a happier time at school than without it, then yeah, of course, take it, but work with your psychiatrist. Or, as Dr. Glazer said, there's not a lot of child psychiatrists. It's a tough field, and so oftentimes pediatricians or folks like me, pediatric neurologists, act as a de facto kind of B-level psychiatrist for many of our patients. And so we do the best we can, but we have a lot of experience working with these medications. Other things that we can do besides medications, when folks come to see us, we want to make sure that the rest of their development and senses are working well. So we want to ensure vision is good. So we want to make sure that we link folks up with a good pediatric ophthalmologist. Make sure hearing is good. Make sure kids are getting good sleep. I think Dr. Shinawi had mentioned that earlier. Sleep can be an issue. Sleep is an issue in a lot of neurodevelopmental conditions, and having bad sleep, as probably anyone in this room can attest to, makes you not function properly. So the same goes for children, of course. And so any condition that you may have, aggressive behaviors, ADHD, anxiety, if you're not getting sleep, they're worse. That's a rule. Nutrition also plays a huge role. There's not a specific type of food that you should avoid or stick to or anything, but generally we think, avoid as many processed foods as possible, stay away from too many processed sugars and things like that. But make sure you're eating enough calories, all of those things your brain needs to function properly. Then the other role of the neurologist and pediatricians as well is to make sure folks are linked up with the right type of therapy. So physical therapy to help with those gross motor skills and balance. Occupational therapy also can help with those balance skills, but also fine motor skills. At young ages, occupational therapists can be really helpful in helping with behavior management and stuff as well. Speech therapists, not only for language development, but for feeding, all of those apraxia type conditions. In fact, to diagnose speech apraxia, oftentimes people will see a speech and language pathologist who will do that. and then figure out good exercises to help somebody eat better and swallow better without choking, etc. Behavioral therapy, that's very important, obviously, and Dr. Glazer touched on those. And then educational supports. And so our teachers and school administrators are our partners, and oftentimes spending the most amount of time aside from families with children, and having a good, what's called an individualized education plan, or what's called a 504 plan. 504 plan, it was through the Rehabilitation Act of 1973, was an important law that was put into place to help folks who have a variety of disabilities have a fair, safe, and equitable kind of learning experience. And so it's not special education or changing the curriculum, but it's modifications such as, oh, you have ADHD, you can sit closer to the teacher, or you can have a different kind of seating, something like that. So all of these things designed to support someone's function in the classroom. The next thing that's very important, seizures and epilepsy. And so what is a seizure? A seizure typically is a stereotyped, discrete event that's caused by unhealthy or abnormal electrical activity in the brain. A professor of mine said, anything that your brain can do, you can have a seizure that does that, but in an abnormal stereotype, kind of like a broken record sort of way. And epilepsy, what that means in very plain terms is it's the brain's predisposition to have seizures. Anyone can have a seizure if I hit you in the head hard enough, or if you get a brain infection or something like that. But if you have seizures just as a, because of the way your brain is wired, that's what epilepsy is. And so having 2 or more unprovoked seizures, so seizures for no reason, out of the blue, that's just the way you were born type seizures, that's what epilepsy is called. It doesn't mean you have a specific type of seizure. It means any type of seizure unprovoked, 2 or more. Or you have 1 or more seizures with some other evidence that you would have more, like you have a brainwave test that says you are at risk of seizures, or you have an MRI picture of your brain that says, hey, this part of your brain is built very abnormally, you're probably going to have more seizures, or if everyone in your family has seizures, or something like that. So 1 seizure plus a high risk, and that's very subjective, but a higher risk of seizure qualifies as epilepsy. There's a high level of subjectivity with neurologic diagnoses. It's not like orthopedics where you can look at someone's broken bone or something like that. But it's important to make these classifications so that we can kind of decide if somebody needs to be treated and what to treat them with. A brainwave test or an EEG is helpful, but it's not the most important thing in the world. It helps us figure out if somebody is having seizures, where in the brain they're coming from, if it's a specific type of epilepsy syndrome, which might help us figure out what medicine to use. But it doesn't tell us, let's say, if a seizure happened last week. It doesn't tell us if we're about to have a seizure in the next 2 days or something like that. It really only tells us the surface level brain activity at the time of the recording. Sometimes, if you're really lucky, or if you have an EEG on somebody for a long time, you can capture an episode to determine if it's a seizure, but we're not always that lucky. Seizures are treatable. The variety of medication, there's, I don't know how many now, between 26 and 30 different seizure medications, which also speaks to the fact that they're not perfect. If they were perfect, there would probably be only 1. I'm not going to list all the medications here. One medication, so Dr. Glazer had mentioned levetiracetam or Keppra. It's a notorious one that can, it's frequently used as a first line by many neurologists for a variety of seizure types. It can work well, but it can worsen aggression or psychiatric issues. Sometimes people use vitamin B6 to lower those types of symptoms. The data on that's not super awesome. They say in 50% of people it works 50% of the time, which sounds like a made-up statistic. Maybe it is, but it's also harmless. And so this is, once again, I think I addressed this on the last slide, but a lot of people have some thoughts about what an EEG or electroencephalogram can and cannot do. Can't predict the next seizure. It can't tell you if a seizure happened in the past, but it can tell you, if you're having a seizure during the EEG, or it can tell you the type and where it's coming from. And this is a little example of what they look like. And so when they're slapping stickers on your head, it comes out with this nice little tracing, and you can localize where in the brain there's an issue. And one other point with that is that sometimes seizures don't come just from the surface of the brain. They can be generated from deeper in. Very small seizures, somebody twitching their hand just a little bit, might not show up on a surface EEG, and you either have to use your intuition and treat it empirically, or you have to do kind of more in-depth brain surgeries and insert electrodes and things. Not a lot of people need that sort of thing, but that technology does exist and is used routinely to find seizures that are not otherwise commonly found. And so when should somebody get an EEG? Sometimes people ask, oh, we have a syndrome that can be associated with seizures. Should we get an EEG? My answer to that has been no, because if it's abnormal, but you're not having any seizures at all, what are you going to do but become worried about it? Sometimes if there was a known association with what we call subclinical seizures, or seizures that you can't see, sometimes we do more prolonged EEGs, and we say, oh, when you fall asleep, you are having a ton of seizure activity that we can't really tell, but you should be on medicine for this. And so sometimes we'll do that sort of thing. But really, the story, what happened, what did the child act like afterwards or before, what were their eyes open, closed, all these different things are way more important than any medical test. Story is super important. And so I always tell folks, if you're concerned about a seizure, obviously stay calm. That's easy for me to say behind a podium, but stay calm. Time it if you can. And then look at what the eyes are doing. Look at if it involves the left or the right side, things like that. Those are the questions that a neurologist would ask you in the office to figure out what type of seizure this is. Oh, this is a seizure arising from the left hemisphere or the right hemisphere, or this is a deeper type of seizure. We also get EEGs before big medication changes sometimes. Certain medications can make it worse or make you have more seizures. Sometimes we get it to capture a spell. Somebody says, I'm having this weird thing. I don't know if it's a seizure, but it happens 6 times a week for the past forever. Say, oh gosh, if we got an EEG, we're gonna catch it, we'll get lucky. So then we admit somebody to the hospital or send them home with an EEG to do that. Or we get another EEG or many EEGs if we're really trying to find a spot in the brain that's abnormal when you're considering brain surgery. Okay, this spot is just generating seizures, not doing anything else useful. Maybe we should remove it. Obviously, an EEG to figure out what that spot is super important. And so in Dessh syndrome, per the literature that I've seen, not everyone has epilepsy. It's not a rule, as Dr. Shinawi mentioned. It's not even a majority of the patients. And if you do have epilepsy or seizures, it's a common scenario for these to be treatable with medication. Epilepsy in general is treatable with medication. It's uncommon to have what we call refractory epilepsy, which is you've tried 2 medications and they were good medicines, you didn't choose the wrong ones, but still seizures are happening. That's called refractory epilepsy. And in those conditions, you can use dietary therapy, consider surgery, implantable devices. There's something called a vagal nerve stimulator. There's something called an RNS. There's something called deep brain stimulation. There's a variety of different things, which is outside the scope of today's talk. But there's a lot of epilepsy technology out there. And actually, we have an epilepsy clinic that Dr. Weisenberg, who you met, works in that discusses these new types of technology with patients. And I think we touched on this earlier. In general, epilepsy should present in childhood. By adolescence at the latest, it's unusual, but obviously, like, the brain doesn't care what I write on a slide, can do whatever it wants, and can happen where you have a seizure later. But typically, this skews younger. And we don't have great statistics yet because the numbers are not huge. So neurologic management in general, this is very small. I just had changed the font when I tried to change the color. But when I monitor development, medication management, that's what the neurologist or the psychiatrist is going to do, and then connect patients to therapies. And so making sure, a lot of times patients ask, where can I get occupational therapy? Where can we live in wherever, and we want to do this. And so part of my job is to link folks up with those things and know these things. And the next thing is knowing what to do in terms of epilepsy, how to manage refractory epilepsies. The goal is not to say, hey, we'll make you have a couple less seizures. The goal most of the time here is going to be to eliminate seizures, 0 seizures if you can have, because seizures can be dangerous. If you're having many, many untreated seizures, the thought is that it can affect your cognition and it can lead to a regression. And then you got to assemble a team. So, somebody's got to steer the ship. Frequently, it's the pediatrician, but you have therapists on your team, physical, occupational, speech, feeding, behavioral therapists, as well as your medical team. And when you're picking physicians, make sure you pick folks that are responsive, answer your phone calls, and advocate for you. Sometimes people go and see a doctor and they told me that I had intellectual disability, they told me I had this or that, and what are they going to do for you? Nothing, they just told me. You don't want that. You want someone who's going to try to help you with it. That's super important. And someone who listens. School and community, that's obviously very, very important, and goes without saying that organizations such as this one are super important. And we didn't have this 20 years ago, social media and this kind of stuff to connect families from all over the world. A physician like myself may see 2 or 3 patients with a specific condition over the course of my career, where everybody with the condition has met each other on Facebook or at meetings like this or something, and that, I think, is way more valuable. And so I think that this is a really wonderful type of event, and you can figure out what works for other people and bring it to your doctor too. So you guys are a part of each other's medical team, so to speak. All right. And I guess I didn't put my email on there, but that's our phone numbers. And then Dr. Weisenberg, who you guys talked to yesterday, it's 2 different phone numbers because we have satellite offices, but we're both pediatric neurologists, and we are accessible. You can reach out to us. And if you do need our email addresses, we can get those to you too. Thank you.
Thank you, Dr. Papik. So we have a good 20 minutes left for your questions for these 3, and I'd like to, it can become a dialogue. That's sort of how we formatted this session right now, because I know there's a lot of crossover, particularly with neurology and psychiatry. So please raise your hand if you have a question. I'll bring you the mic. If we hear crickets, I've got some questions that folks submitted online. Oops.
I know we kind of briefly mentioned this earlier, but what is the occurrence, or what should we be looking for seizures in the older children if they've never had any as a baby?
So, like I said, seizures, it's broad. Anything that your brain can do, a seizure can sort of do. But in general, what I tell folks is that if you have a spell, we use the word spell a lot, but or spell or an episode of a behavior that seems out of the normal for you, like, oh, we were talking and then in the middle of the conversation we just blanked out and started staring. We've never done that before. Now it's happening a bunch. Or we have uncontrollable movements of our limbs. It can be anything. Repetitive movements of our mouth, like repetitive chewing movements that are associated with maybe not quite being there, zoning out or something. Those would be reason to bring that up to your neurologist and talk about potential seizures. Other things that folks might not think about, because obviously we can't look at somebody 24 hours a day, but sometimes people might have a seizure in the night. And, I've met patients who say, gosh, we started having urine accidents at night, and we never had this before, and we've been dry for years, but we've had this, and gosh, we bit our tongue in the middle of the night. What happened in the middle of the night? Those kind of things point us to looking into seizures. And obviously, there's probably a lot more, and we could talk for hours about this, but those are the big things that I tell people.
Mine might be a little bit of a crossover between psychiatry and neurology, but going through the medication recommendations that you gave, if they don't have a history of seizures, would you recommend avoiding Wellbutrin because of the increase or possible increase in the central nervous system stimulation, and with these patients specifically? At
low doses, I wouldn't. If there's a bigger, like a family history of seizures, then I might, but there's also so many other things that I would think about first that I might not get to that point unless I had to,
Right.
in which case the benefit may outweigh the risk. But if somebody has seizures, then no, I'm not going to use Wellbutrin.
And then my other question, shoot, it kind of slipped my mind. There's another one. Oh, it was the Namenda question. Since this would be like an off-label use, is there like a certain diagnostic code or anything that you would like recommend for getting that approved?
The way I've done it is I've just prescribed it without, I've told the pharmacies don't run it by insurance,
Okay.
and then use the GoodRx app.
Okay.
And it's a super cheap generic, so it ends up being around $5 to $30
Okay.
a month, and well worth it if it helps
Okay.
at that money. But yeah, every time an insurance has looked at it, or sometimes I even have to call the pharmacist and say, look, do not freak out that the patient is 15 years old. I'm not prescribing it for Alzheimer's.
Right.
So yeah,
Okay.
it does, thankfully it's very cheap.
Thank you.
This is, again, a crossover in Dr. Schnaui even. One of the things we've experienced with our son that our doctors have talked about with us is like a honeymoon for medications. So like a medication will work wonderfully, and then it just kind of stops. And then we go up in a dose, works wonderfully, and it stops. And a couple of doctors have called it like a honeymoon period for drugs. Have you guys had experiences with that? Because like for our son, on the seizure meds, we have been through the gambit, Trileptal, Depakote, Onfi. Now we're on Lamictal, and they seem to work, but then it's like we hit a wall, and we have dosed out of things.
Yeah, it stinks. Yeah, no, so we see that a lot with a lot of patients, and I'm sure you see it as well, at the brain, so to speak, becomes used to a medication. I see it a lot with like ADHD medications, but seizure medications too, and it requires you to change to something that has a different mechanism of action. And there's not a good prediction model of like which medicine that's not going to happen with, unfortunately.
Yeah, and my only experience is some patients never do it, and some do it a lot with every medicine. So it's hard to predict even that. But once you do, switching medicines, and even going back to ones that used to work sometimes is the best policy.
Hi there, I'm your ring-in foreigner from Australia. I've got a question from one of the other Australian parents who couldn't make the trek over here, asking about PVNH and whether there's any correlation between that and the Dessh seizures, because her daughter was recently, at about 27, diagnosed with the periventricular nodular hieratonia. You'll say it a lot better than me.
Heterotopia.
Yeah, that one. And that hadn't been noticed, but apparently it is part of the brain from birth. So she was interested in that one. After that, I've got another question, but I'll let you go with that first.
Sure. So as far as I've read, I don't think that there's a specific association between specific brain abnormalities and Dessh. There's been a variety of things described, and it's not clear if those are directly from the WAC protein mutation, like hydrocephalus. Periventricular nodular heterotopia is where you have little nodules of your cortex or your brain cell tissue that is deeper in the brain, like kind of where it should not be, like ectopic brain tissue, basically. And those little nodules don't do anything great except make seizures and problems. And so it's not specific to Dessh, but it has to do with how the cortex in the brain is formed early in development.
And I would answer that in a different way, since I'm the staff pediatrician for a study called the ABCD study. and we scanned 10,000 8 to 10-year-olds across America, and we found the periventricular nodular hypertropia in thousands of normal kids. So probably the best way to answer your friend is to say, listen, it's there in a lot of people, and we still don't know really what it correlates with. So it probably has nothing to do with the Dessh per se.
Okay, great, thank you. My other question is also to do with seizures. Is there any difference in terms of regressions and things when it's a physical seizure versus an absent seizure?
One seizure shouldn't cause somebody to have a developmental regression. Having a number of seizures that are untreated can cause that, and then it doesn't matter if it's something that makes your muscles move versus something that doesn't make your muscles move. I think it just has to do with the actual seizure burden that somebody is experiencing that can lead to that. But it's not a common scenario where somebody will have a few seizures and then developmentally regress. That's a more severe scenario.
Okay, so my little boy, for example, we just had the EEG for, and he was getting them every second in his deepest REM sleep, the absent seizures, and then quite regularly during the day as well. So getting medicated for that is a priority, I assume.
Yes, I would believe so. I mean, without knowing the specifics, I can imagine so.
Thank you.
Yes.
One question came in online about eye ulcers. Has eye ulcers been something that has been seen in the Dessh population?
I've never heard of that. I don't know if you have, Dr. Schnaui. I wonder if it would be like some neurotrophic corneal problem, maybe. But I haven't seen that or heard of it. But it would have maybe like bad dry eye or decreased corneal sensation or something like that. And there probably would be like a lot of signs before you got there.
As a follow-up, they ask, can they be treated preventatively?
I guess it depends on the cause, but presumably so another thing I guess to think of would be if you had a really restricted diet and like a vitamin A thing. But first you'd have to figure out the cause, and then if it's a dry eye cause or a neurotrophic cause, you'd probably treat it with like a tarsorrhaphy, or really frequent eye drops or something along those lines. But you'd have to figure out the cause, and then definitely you would treat it, because you shouldn't just get eye ulcers for no reason.
Oh, it's for you?
So I'm curious about the seizures in the night thing. You said biting your tongue in the middle of the night. What other things might there be? Like if somebody starts to suddenly grind their teeth at night, would that be something? I mean, how do you know if anything's happening?
So most things, I mean, people do a lot of weird stuff in their sleep that's not seizure. People do a lot of weird stuff when they're awake that's not seizure as well. So not all staring is seizure, not all like twitching or whatever is not a seizure. But tooth grinding in the middle of the night typically does not go along with seizure. If it's something where you continue to sleep through the event, it's not going to be a seizure. For witnessed events, if somebody wakes up out of sleep, their eyes are open, and I say wakes up, but they're not quite there, and then they begin having the spell in question, that would be more concerning for a seizure. I know a lot of people that twitch in their sleep, but it's just twitching in their sleep. They might continue to be asleep. If we put an EEG on them at that time, their brain waves would just show normal sleep rather than a seizure. If the story, when presented to the neurologist or whoever, sounds suspicious, then they might say, well, let's get an EEG overnight, and a number of centers do this, and they can see what your brain is doing when it falls asleep. Sometimes if we think, gosh, this is not a seizure, but this is an abnormal sleep behavior, maybe it needs to be treated with iron supplements or something. This is restless leg or something like that. We might order a sleep study, polysomnogram, and then they can hook a bunch of wires to all different things in the middle of the night and check on that sort of stuff. And so it's a good question. Not all weird stuff you do in sleep is a seizure. Few things are, but those, biting your tongue, having blood on the pillow, or going to the bathroom on yourself in the middle of the night, those are just clues that you see afterwards. That's not the actual spell. Those are things that might happen, and then you wake up the next morning and you see that somebody has done these things, and so there's just clues for a seizure. Acting really confused in the morning. I mean, most people drag a little bit in the morning, but acting way more confused than normal when you wake up, that would kind of clue somebody in to look for seizures.
And just one other really quick one. I'm assuming there's always like an absent sort of look, or like when you said like arms twitching or something,
Yeah.
you're going to see something in the face too, right? It's not just going to be
Potentially, but not always. And so I mentioned that there are some little focal seizures that can arise for very small parts, maybe even deeper in the brain, that can produce abnormal muscle movements, twitching, without impairment of consciousness. That's called a simple focal seizure, a simple partial seizure. I've had kids who are like, hey, I can't stop my thing with my arm, and you put an EEG on them, and sure enough, they are seizing. And so awareness being impaired happens in a large number of seizures, but it is not the rule, and there's a whole classification of seizures in which awareness is not impaired at all.
Thank you.
Yeah.
Hello, doctor. Is atropine recommended for a 4-year-old? Atropine eye drops.
Oh, you for myopia progression or
For the farsightedness.
Oh, it's not very well studied that young, but it could theoretically be.
Okay.
So what the studies were kind of more around 9-year-olds.
Okay.
And then to start the drops, they're very low risk because it's very dilute atropine, which is one of the oldest drugs. But before starting, you want to see some progression. So usually you want a couple exams, a couple years apart, just to make sure that you actually have progression and that you're actually treating something.
Okay. Thanks.
I think Preston was actually on atropine drops for the eye weakness. They were doing it of the opposite eye to try to strengthen. Yeah.
Yeah.
So
that was probably stronger, so it actually blur the vision. But
correct. That's what they were trying to
Exactly,
do. Yeah. I was going to say so, but it was safe, I guess, because it didn't cause any issues. So this is actually opening my eyes now. I'm feeling kind of silly, but so my son this year started doing a lot of chewing motions, and I immediately thought like tardive dyskinesia because he is on an antipsychotic. He's been on it for years. But it did kind of start to slow down, which I did not expect with dosage adjustments. And so now I'm wondering, because he did have an epilepsy diagnosis, he was on seizure medicine for years, he's not on any at this time. Is that something we should mention and possibly get another EEG? Is it worth it if it's not regular or causing any increased issues that I'm aware of?
You should always mention it. Anything that comes to your mind, I regret it if you don't mention it to somebody later. But I think that, if it really depends on the story. So if it's constant and it kind of lowered when you lowered certain medication doses, then probably is not a seizure.
Well, and I don't know that it was ever constant, but it would come in spells. He would do it. When he was doing it, it was several times a day.
Yeah.
And then I might not see it for a little bit, but I just didn't know, with him being difficult, how much I should pursue it, or if I need to be worried about it progressing back to something more severe, I guess.
Yeah, I guess that goes back to having a medical team that listens to you. And so if you bring this up and say, hey, I'm having episodic, chewing spells, then they're going to ask you more questions about it, and hopefully not, brush it under the rug. But if they ask the right questions and you say, oh, no, he's not doing this or that or whatever, and they say, okay, no, then it's not a seizure, it should be.
Because kind of where I'm going with this a little bit more too is with the behaviors, so our neurology exam here did not happen because he was not cooperative. We just saw our neurologist again last month, same thing, will not let him do an actual exam. And I have multiple concerns past seizures. And so I'm worried about progression of some of these things, the spasticity and there's just a lot going on, and I don't know how to pursue that, because it always seems, well, I mean, we can just watch it. And I'm like, well, you're right. And of course, if we get to a certain point, but then at that point, is it too late? Has there been some permanent damage or anything? And so that's where I'm struggling is, do I force him to do some of this workup and then how good is it going to be if he has to be sedated, like doing EMGs? And I know that they can still be done, but.
Yeah, but you're right. They're not as useful
Right.
if you're asleep for that, but because sleep medications are good seizure medications also. So, I think that's where having a really good story, if you have videos of these things, neurologists love looking at videos.
Okay.
We look at videos all the time. And, that could be like, hey, here's a video of him walking, and here's a video of him walking last week. It's very different, as you can see. So we
Okay.
will review these things. That's super important because oftentimes in a novel, situation like someone's office and they're wearing the white coat and
It's
getting your
stressful,
blood
right.
pressure checked, nobody wants to do any of that stuff. And so oftentimes seeing what somebody's like at home is way more valuable, I
Okay.
think. And so we
Thank
do
you.
use that, yeah.
Okay, we have time for one last question.
Actually, I wanted to. Can I ask Dr. Shinawi a question? Okay, cool. Well, when they brought up the ulcers, it made me think of mouth and GI. What are the ulcers, that is? And do we know of any issues with mouth and other GI ulcers?
Yeah, I'm not aware actually of the presence of these, at least based on the data that I'm having. What exactly, why you're asking this question? This is related to?
Just reoccurrence of ulcers.
Oh.
Dentists, we have a paste that we have at home now because it's so frequent.
Yeah, I mean, to my knowledge, at this point, I don't see any connection, at least based on the data that we have between these two.
Thank you so much. So I imagine these doctors might make themselves available for a few minutes if you guys have any more questions, but it's time for our break now. We've got about 15 minutes. Feel free to check in on your kid. There's some more snacks back there. And we'll be back at 10:45. And thank you once again to this awesome panel, Dr. Glazer, Dr. Reynolds, and Dr. Pathak. And another member of our medical team is Dr. Daniel Vogt. He comes to us from Michigan State, and I'm sure he will tell us a little bit about himself when he comes to the podium. But he has been working on WAC gene in mouse models, and also with another member of our medical advisory board, Dr. Kim, who has a zebrafish lab in South Korea, and they've been studying WAC gene in zebrafish as well. So we even had him here today. He's so graciously traveled to be with us, to speak with us a little bit about the research that he's come up with. So put your thinking caps on. It's a little bit of a twist from the clinicians we've spoken to this morning, but I would love to welcome Dr. Daniel Vogt. Thank you. Or there.
Okay, great. Thank you. I appreciate it. It's really been great to meet you all over the last day or two. I was joking, but it's true. I've been on Zoom with you for like 2 years, and it's great to just meet and get to know you. And, whatever we can do, we're here to help. We're here to figure this out to the best of our ability with the models we have. And by generating a model, we hope that if we can get to the point where we have targets, we can treat the model as well to come up with therapeutics and drugs, whatever we can do. So that's kind of what I want to present to you today. I did talk with Dr. Kim, and he gave me permission to share some of his stuff as well. We've been collaborating and working together to try to get our animal models out and do the best we can to get it published. So with that, I'll just... Oh, that's great. Thank you. And so today I'm going to present animal models of a mouse and of a zebrafish. Both of them are vertebrate models. They both have their advantages, some things you can do in one that you can't do in the other. But by having both of them, it gives us a larger toolkit to use. What we are looking at right here, this is just a prediction of what the shape of the WAC protein looks like. I'm going to call it WAC for brevities. just easier for me. But basically, this is the shape. And the shape of a protein is its function. And when there's a change in an amino acid, or when it's truncated, or there's a frame shift, you either don't get the protein or you have a different shape of the protein, and that's what we're trying to understand. And I'll go ahead and preview this, but I'm going to talk about the animal models and kind of what we're finding, and then when I end today, we're going to be followed up by Dr. Harrison Gable, who's going into some of the mechanisms about how this protein could work. And so the way I like to think of it is I'm trying to understand how the kitchen works. So our DNA is every recipe we could possibly make. The cells in our body, they're not going to make all of them. They're going to pick a certain repertoire. They're going to be a certain type of restaurant. They're going to make Thai food. They're going to make Mexican food. They're going to make something else. But that's their menu. And that's what we're kind of understanding in each cell type. My lab especially looks at brain cells. We're very interested in how our neurons work and how they function. And because of this, we wanted to use a model or develop a model where we could study the brain and get as close as we could to having something to manipulate to understand this gene. So when we have a mutation in WAC, it happens at the DNA level. A lot of these, as Dr. Schnally mentioned earlier and other people, these are often de novo. And they occur all over the protein. We're still trying to understand what it means to have a mutation, say the first part of the protein, the middle, or the last, and understand what that means as well, kind of as a predictive measure of the types of symptoms and phenotypes we might have. And what's been described so far is, I think, the vast majority of the mutations, they lead to a change in the DNA that leads to a reduction in the amount of the recipes that we get. And that's shown here by the little RNA you see in the middle. And that what this results in is less of the protein being made, and that's sufficient to see a lot of the symptoms that we're observing. And it's more rare, but we also want to understand what it means if you have a change, but it just changes a single part of this recipe. This could be like not adding salt to the recipe. You're still going to get a cookie, but it may not taste the same. And we want to understand what that does to the protein, because that's going to inform us. And again, probably about 10% of the patients have these mutations, and we do want to understand that as well. And again, what we're trying to do is develop a model for the vast majority of these mutations. These are the loss of function of one of these copies. And again, well, you might hear me say this, but I call it missense or single unit change for the other mutations. But the vast majority of what I want to give you for a model today has to do with this loss of function. And so I want to start by saying this would not be possible without a collaborative team. And I really appreciate Caitlin for putting this together. I wouldn't be here today if they had not approached me and said, come meet us and work with us. And because of that, we're not just researchers and parents, we also have a great clinician, Dr. Schnally, that's kind of guided us. This is what the team looks like, and this is great because when we all come together, we're going to learn from each other. I have learned a lot, and most of that is because the parents have come to their clinicians and said, here's what we see. And then we take that and we try to go reproduce it in our labs. Excuse me. I also just want to say thank you to a lot of the collaborators. Dr. Harrison Gable is here today. He's going to present some of the mechanisms. Dr. Kim, who's in South Korea, has developed the zebrafish model, which I'll present. And I also want to say thanks to colleagues that I have known and worked with. Alex Nord at UC Davis, Juhee Jeong at New York University, and a collaborator at UC Irvine. All of these people have pitched in to look at this mouse model and help us understand what's going on. So what does a WAC recipe look like? This is basically 3 different species, human, mouse, zebrafish, all lined up. So just like a real recipe, we can imagine a protein sequence in letters, and all these letters have properties. So I like recipes that have 3 or 4 ingredients because they're easy, but this one has 667. But and each one of these has a purpose. But what we like to do is try to understand what the domains are and what they can teach us about the protein. And I like to imagine proteins like Lego blocks. Like every single block has a purpose. Some of them look alike, but the way you put them together gives you an airplane or a car or something else, just how you build it. What you're looking at, the colored regions here, these are areas that in all of the species we look at don't change. That means they are incredibly important. We call these conserved regions. And actually, the name of the protein, WAC, is named after two of these. The blue area that you see, this is what's called the WW domain. It is basically a sequence of proteins that have a shape that can interact with other proteins. And the reason we wanted to make a mouse is because, and especially in brain cells, is because the WW domain is very common in proteins. So the way it's presented on the WAC protein, it can have a different binding partner in a neuron cell, in a mouse, and in a human versus a fly. And because of that, we need to get as close as we can to a mammalian cell type as we can. The other domain that's well known is at the very bottom here. It's in gray. This is your coiled domain. It is another protein interaction domain. So like Lego blocks, these are like the little pieces that stick out that you connect to each other. And again, it can bind to other coiled domains. And what we don't know right now are some of the intricacies about the binding partners. That's something that I think Dr. Gable is going to get into, some of the candidates that we think are going on. And the more candidates we have, it means it expands our repertoire of things we can manipulate. We just did a study that came out this year, actually. And what we found is that there's two other domains that were unknown, but are probably very important. The first one is in red. This is a predicted nuclear localization signal. What that means is basically like a zip code. It tells a protein where to go. And we found that if you get rid of this domain, you no longer get the WAC protein to go into the kitchen. And the kitchen is where the recipes are. That's where the DNA is. And we think that WAC is very important for modulating, making the recipes that make the proteins. The other domain, we don't know what this is because it's not been seen before. It's this large yellow domain in the middle. What we think it is a large on and off switch. We don't have good evidence for this yet, but it's basically a large domain that has these things called phosphosites. And there are signaling pathways in our cells that use modifications. So they can put things on and off a protein to basically change their shape. And when they're doing that, what they're doing is turning a protein on or off or telling it to go here or there. This yellow region has about 10 of these sites, highly densely packed. And we're trying to understand right now if any signaling pathways regulate the WAC protein. The advantage of this is that a lot of these signaling pathways have FDA-approved drugs, and we want to know if any of the signaling pathways can be modulated to affect this protein. What we know right now is that there are sites, but we haven't figured out yet which signaling pathway or if it's even affected by this. So this is ongoing research. So what we're doing, I guess the first step that we wanted to do to understand the function of this protein and its relevance to Dessh is have a model that can actually reflect or recapitulate some of the symptoms that the patients have. So what we did, and just to preview, the model that Harris and Gable will present also uses the same type of mouse. Basically, we got a mouse from what's called the Mouse Knockout Consortium. They're trying to make a knockout of every gene possible so that this is available for researchers. We brought in the DNA to Michigan State. We made the mouse there. And luckily, we were able to produce both what's called wild type and heterozygous. So the heterozygous mice, these are mice that lack one copy of the WAC gene. So to us, this would be equivalent of the vast majority of mutations in the WAC gene that patients have. Figure A is just how we did this. So a lot of genes, they're very spread out, they're very big. And so we can't target the whole thing, but we can target a piece of it. By doing this, we're generating the same type of like frame shift mutations that a patient might have. And what we're finding is that because of this, the RNA that is made from this mutant is degraded, and so you get less protein. Dr. Kim's lab had to take a little bit of a different approach. Zebrafish is a little more complicated because they have a duplication of all their genes. So they have an A copy and a B copy. And he found that when he gets rid of the A copy, he gets phenotypes that resemble some of the patients. But the main thing to take away from this is both of these models have about half of the WAC RNA and protein missing. And that was our real goal. So I don't have all the symptoms up here, but I do have some that we've been looking at. Unfortunately, my lab can't do everything, so I just want to pitch it out there. If you're talking to their doctors and they're at a research university and someone is interested in this, let me know. I will ship them the mice. I would love to share it with people. The main things we have so far are things that either my collaborators could do or my lab knows how to do. And I'll talk about some of the stuff that Dr. Kim's lab has done too. Two of the things that we've started on are craniofacial and behavioral assays that we had access to. And both Dr. Kim's lab and my lab has found that our mouse models do exhibit some of these. We're looking into ways to look at hypotonia or muscle tone. We haven't been able to do this yet in mice, and I don't think Dr. Kim's lab has done this either. We have looked at seizures. We do see some seizure phenotypes. I don't think Dr. Kim has done this yet. Sorry, I didn't finish this, but the other things we're trying to look at now are gastrointestinal and blood glucose. And we're starting to find a little bit of a hint at blood glucose, and I'll maybe ask you about this or end on this, but we have a trend right now towards lower blood sugar when they're born and higher blood sugars later when they're adults. And that's kind of what we're seeing right now in these mice. I'll first start by introducing our colleagues at NYU. Excuse me. So Juhi Zhang and I were postdocs together in California, and she developed a really strong program at looking at craniofacial development in mice. So the moment we got these mice, I asked her if she'd be willing to do this, and she said yes. So we shipped her mice. These are what they look like. So at the top of the head, you probably noticed in the first image of the mice I showed, you can't really tell the difference because of all the fur they have. But if you look just at the skull itself, we do see that there's, at least in the frontal and somewhat in the parietal, this is basically the equivalent of a forehead or in top of the skull. We do see a widening of this, so this means that we don't have as much skull tissue in the frontal and a little bit in the parietal, and this is just quantified down here in E and F. So there's a bigger space or a widening of the frontal bones. And if you look later, we still see this. It does seem to catch up a little bit. The parietal goes away. This seems to be totally normal when they're P30, so this is what you would consider a young adult, or they just got their first car, you know. And what we see is that it's still a little bit wider, and sometimes it doesn't close all the way in the mice. This is as far as we've gotten with the craniofacial, but if there's anyone else or you know any researchers or doctors that are interested in this, they do exhibit this phenotype, and we're more than happy to share the mouse. Dr. Kim's lab also noticed a widening of the jaw in their studies. It's very subtle, but they've noticed consistently the lower jaw in the zebrafish is actually wider in their model. The other thing that we found, this is one of the first things we did, is look for seizures. I can tell you that when we go in and take care of the mice and we handle them, they don't have overt seizures. We've never witnessed one that just has a fully convulsive seizure. But you can challenge them with a drug. This is a drug that actually lowers GABAergic tone, so it's going to make the brain a little more excitable. We use what is a sub-threshold dose. So in a normal mouse, you give this dose, and they might be really calm and just sit still for a while, but they don't have a seizure. When we give this same dose to our WAC heterozygous mutants, almost all of them have a convulsive seizure. So the brain seems to be more excitable, at least in this model, even though they're not having overt seizures on their own. And we've looked all over the brain for evidence of this. We do see a little bit of a molecular marker called FOSB in one little region in an area called the hippocampus. This is an area important for learning and memory and like navigating spatial areas. But for the most part, most of the brain, we don't see this marker except in this one region. But it is evidence that there might be some excitability in the hippocampus. Part of the reason for doing this is we're trying to figure out if there's certain areas of the brain we should be focusing more on, because in these het mice, I'll show you in a bit, it's very, very hard at the anatomical level to see anything. They look really normal, and that's a good thing because it means all the pieces are there. But I think this was mentioned earlier, how it functions and how things are operating are off, and those are really hard to find, and that's what we're trying to figure out. The other thing we've done is behavior. We've done a panel of behaviors on these mice, and several behaviors we have no changes. So we've tested for anxiety, locomotion, learning, and like really intense learning and memory. And what I can tell you is that there's a cohort of about 20 or 30% that seem to be doing a little worse in some of these behaviors. But as a group, they're not reaching a significant level. So as a group, there might be sub-cohorts of these mice that are more susceptible to the behaviors. The two that do stand out to us that have reached significance as a group are the Y maze and a 3-chamber social interaction maze. What the Y maze is it takes advantage of a mouse's curiosity, and it's like a short-term memory test. Mice love novel environments, so what we do is we give them 3 choices. And what they'll normally do is they love to explore, so they always explore the arm they haven't been in. And if they can't remember or they have short-term memory problems, they'll make a mistake and go into the same arm over and over again. And our mice do show a little bit of that in this test. It's not an exhaustive test. We have tried more robust tests, and in the more robust tests, the mice actually do really well. The other one that stood out is how much time a mouse would spend with another mouse versus an object. Again, mice have curiosity, they love social time, so we just measure the amount of time they're spending with another mouse. And normally what you see is between the mouse and the object, oh, and I'm sorry, I think these are reversed, but, oh no, this is correct. Between the mouse and the object, there's more time spent with the mouse versus the object. The line just means this is the same mouse. So we wanted to compare the same mouse in for each time. We do have a few mice in the het group that did okay, but the vast majority of them, the line is flat. And then we have the one mouse that didn't behave. And there's always one, but I have no reason to exclude it. So every now and then they just sit on one side and they're like, I'm fine. And that's it. And what I think is really impressive, and I really like Dr. Kim's behavior for this, because we can measure one-on-one mouse time. But what Dr. Kim can do is he can take a whole school of fish and ask how they act together. And what he's done is actually taken his wild-type fish, and his mutant fish, and just scored them for how tight they swim together. And this is a measure of like their social cohesiveness. And what you can probably see in the heat map above, so the darker red means that there's more intense time there. The wild types really like to swim together. They're really tight and cohesive. The whack mice, unfortunately, go everywhere. And they're also a little hyperactive in this test. So this is actually, I really like this a lot because I think it really highlights, as a group, how this mutation actually is impacting social cohesiveness. So it's also a good comparison between the limitations of the mice versus some of the other advantages of other mouse models, which I think is really important. I keep saying mice, but I mean fish. The other thing, and this is very new, is trying to understand metabolism and metabolism in the mice. I don't have all the data for this, but I can tell you we've taken more steps than just looking at heterozygous mice. We've tried to knock out both copies of the gene in a very selective manner so that we can pinpoint where in the brain is going to be most effective. When we've done that, we started noticing that the mice actually were gaining a lot of weight. We think this is brain restricted to an area called the hypothalamus. But because of that, my lab manager, April Stafford, she recently had her first kid. He's almost 2 now. And when she had him, she had gestational diabetes, and she got really curious about what this meant in our mice. So she had a blood testing machine and a bunch of strips. And she went upstairs to our mouse colony and started testing their blood sugars. And we first did the adults. And what she found is, like, consistently, there was usually a higher blood sugar in the whack mice. We now have a little bit of data for neonates, and it looks like their blood sugar is lower. So we don't know what causes this, but I know Dr. Shinawi mentioned this in February when we had our meeting, and I was like, oh, that's interesting because our mice are doing this as well. We're still trying to collect a lot more samples to make sure this is real, but for us, it's interesting because they start off hypoglycemic, and then sometime in adulthood, they're kind of switching over to hyperglycemic. We don't know the mechanism of this or why it's happening, but we're wondering if the hyperglycemic is part of the reason they might have weight gain as well. Because if you're hyperglycemic, you're going to be making more and more insulin, and insulin is a wonderful factor of storing fat. So it's something, we'll try to get more data on this and let you know more as we move forward, but that is an observation we're noticing. So part 1, so these are what we're noticing in the mice so far. Again, we still have a lot to go. There's still a lot of symptoms that we haven't tested, and we're hoping to partner with other groups that are experts on this. But we do think there are relevant phenotype symptoms in the mouse and zebrafish, including the craniofacial, the susceptibility to seizures, and glucose alterations, as well as behaviors. And again, there's still a lot of Dessh symptoms that should be tested, but we do have an established model. It breeds very well, and we can ship it anywhere as long as we can get some experts to look at it. And again, some of these are beyond our abilities, so we are looking for collaborators. If, again, you're at a clinic and they know researchers that are interested in this, please let them know. And again, yeah, it's very easy to ship the mice. We have a very clean facility, so I don't think they'll tell us no. I came from a very dirty one when I was at UCSF. And in the second part of the talk, I want to get at kind of what are some of the mechanisms or cell types in the brain that we should be targeting to treat these symptoms. And I'm going to talk more about cell types and some of the candidates. And again, Dr. Gable will get in maybe to really the mechanism part of what it could be doing in the nucleus. So in our brains, we're basically really connected. All of our neurons, they want to make friends with other neurons. And they do this through synapses. So they basically send out these long projections called axons, and they will secrete chemicals onto the next neuron to say, get excited or relax. And they do this in a way that's very, very tightly regulated. Our brains have a way of making the right number of cells and getting this nice balance between excitation and inhibition. And when that balance is out of whack, we have things like seizures. We have things like learning difficulties. And that's what we want to understand is if there is an imbalance, can we find the things that regulate the excitability to treat that, or maybe even cell-based therapies later on as these become available. In addition to the neurons, there's a lot of other cells in our brains that are incredibly important for making these chemicals that the neurons need, facilitating their function, and even making them fire at a good speed. These are generically called glia, but they come in a lot of flavors like astrocytes, microglia, and oligodendrocytes. Each one of these are incredibly important for the support of these cells. So what we wanted to do in our mouse model to try to understand if we could find any cell type that was altered, we did a basic panel where we used an antibody to each one of these cell types, and then we counted the cell types in different regions of the brain. I can tell you that almost nothing was different. Anatomically, it looks very, very similar. We recently got MRI data back from our adult mice, and there are very subtle changes. Things like the ventricles are bigger. The corpus callosum has, I can't remember if it's increased or decreased, but corpus callosum in the adults was changed, and a few other areas had very subtle changes. But by eye, it's really hard to see. By MRI, it's very obvious. But when I do a section of a brain and look at it, I can't tell. The reason this is good is it means all the cells are there. We just need to figure out how they're changed and if we can modify them. I mention that because I've studied a lot of other syndromic genes, and sometimes if there's something in development that causes a cell not to be there, that makes it much, much harder. The one change we did find is in a protein called parvalbumin. This is, we use it as a marker for a certain type of inhibitory neuron. And what we notice is that it's really, really subtle, but there's about a 15 to 20% decrease in the staining for this. Those are this is what it looks like in a mouse brain. So this is basically the top of the brain in the cortex. All those little white dots, that's staining for this protein. So each one of those dots represents an inhibitory neuron. We don't think the neurons are gone because there's another protein called LHX6 that is not changed at all. And parvalbumin is a subtype of the LHX6 cells. This is a protein that is known to be altered in a lot of autism gene models. And the reason we think it's altered and very commonly changed is because it responds to neural activity. So if you have increased or decreased activity in your brain, this protein gets either made or decreased. But again, the cells are there, it's just the parvalbumin's a little off. So far, in these particular mice, this is the only protein change we've been able to see. Dr. Kim has also been looking at his zebrafish. So as humans and mice, we have a very big neocortex. This is where we do a lot of our executive processing or decision making. The zebrafish have this too, but it's much smaller. So the red box on the right, this is basically the equivalent of our neocortex. It's real subtle, but this is looking at the RNA for a gene that makes GABA, the inhibitory transmitter. And in some of his models, Dr. Kim is seeing a qualitative decrease. We haven't quantified this, like by counting cells or anything yet, but he's seeing like a little bit of a less staining for this marker in his model. So we are thinking that the deficits that we're primarily seeing are on the inhibitory side of the excitatory-inhibitory balance. And the last thing I'll mention is we're now trying to take a more unbiased approach. So everything I've done so far, we did it because we had the tools in the lab to do it. But we really need to step back and do an approach that might give us more information and kind of step out of our comfort zone too to do this. So we recently got a small grant to do what's called RNA sequencing. And we sent our mice to a colleague of mine at UC Davis, Alex Nord, and Alex graciously agreed to help us with this. So what you can imagine, if you basically section this brain and look in the middle of it, this is what it's going to look like. So on the left side, this is kind of an anatomical representation of what the middle of a brain would look like. And what they can do with this technique, they do one called single nuclei RNA sequencing for us. They can basically separate all these cells into individual units. And then, and Harrison, let me know if I butcher this. I know I'm going. Basically, they can, in each one of these cells, they can then take the RNA and amplify it and tell us how much of the RNA is there. It's a fairly new technique, but it's very powerful because there's two things you get out of this. One is, due to what is in that cell, you can predict what it is. Is it an inhibitory neuron, one of these glial cells, or an excitatory neuron? And then after that, you can ask yourself, well, in that population of cells, is anything different? And those are the recipes we're going after. And that's what we want. This is it's more unbiased approach. Instead of looking for like a handful of like 10 things, I now have the option of knowing if any of our 30,000 genes are changed. So because of this, we can now ask what types of cells are impacted and what's going on in those cells. And on the right, this is just a representation of what this looks like. So they'll segregate these cells into different clusters based on known markers. And then in that group, we can start making comparisons between the wild-type mouse and the mutant mouse. We're still working on this, but we now have a list of candidates that are changed. The two cell types that came up as some of the most impacted are the ones we were hoping, because that's what my lab studies, are the excitatory pyramidal cells and the inhibitory interneurons. There are definitely other cell clusters that we got from this data. There's just so much to present with this, but these are the two that had the most changes. So they're the ones that we're going to target first. In each of what you're looking at here is all these gray dots in the middle. These all represent a gene. But the gray dots mean that there is pretty much no change. If you see a dot to the right, this means that there's too much of it in the cell. If you see a dot to the left, that means it is decreased. So what we're doing right now is we're looking at this list and saying, what are some good ones to go after? There are what are called ion channels on this list. These are basically the things on a neuron that make it excitable or inhibitory. There are transcription factors. These are like the sous chef in the kitchen. They basically take the recipes and decide what to make. And if you get a bad meal, it's their fault. And right now, I just want to say we figured out a few of these we really want to go after. This is Dari. She's a grad student that just joined my lab, and she's actually going to go after a few of these targets. A few of them, I shouldn't say a few, she found out that about 30 of these have FDA-approved drugs. So we first have to validate that the protein has changed. So you can have changes in mRNA, your recipe, but you may not make it to a full meal. And because of that, we first have to make sure in our mouse model that we do see a change. If we do see a change, then we're going to start targeting some of these. The two that she's really interested in are called ERB4 and irregular 1. These two are known to interact with each other between the cells and form synapses. So you need these for the cells to make proper connections and to talk to each other. So we thought these were two really good candidates to start with. But as you can see, there's a lot more on this list. And Alex Nord's group, and I know Dr. Gable's group now has some of these data as well. And I got to meet with Dr. Gable yesterday, and it's really cool because they independently found some of the same changes that we see. So that's good. So I hope we talk a lot more, and we'll figure out ways to collaborate and use those targets. And that's where we're at. So I just want to say thanks again for listening. I hope this wasn't too sciencey. But at the end of the day, I just want to let you know we have models now that we can utilize. Please, again, talk to your clinicians if they're in a research area. Ask them if they know researchers who would be interested in this. We're especially interested in people that would like to look at gastrointestinal problems or other assays that we don't have experience with. And basically, we now have cell types we're going to focus on, and hopefully we'll be able to analyze these targets going forward. And again, any labs tell them. I just want to say thanks to the startup funds. So a lot of this was sponsored by Michigan State University Alliance, which is a partnership between the university and our children's hospital. And Dari, who recently got a funding opportunity, a training grant for 2 years to go after some of these targets. And I want to say thank you a lot to my lab manager, April Stafford, who's been with me from the beginning trying to generate these mice. It was hard, but we got it done. And then just as a transition to Dr. Gable's talk, what we know about the protein, it's not much, but what we do know is that it goes to a certain place in the cell. It goes to the nucleus, so it's in the kitchen. These blue dots that you see, these all represent really dense DNA that's inside our nucleus. And if you look at the top panel, on the left, this is a WAC, full-length WAC protein and it is highly concentrated in the nucleus. And we now have a good understanding of which domains get it there. Because if you get rid of the very first piece of it on the right, you'll notice it's now on the outside. It's not overlapping with the DNA anymore. I hope this is helpful because as we get more genetic information from patients, because we know what the domains are somewhat doing now, we can kind of make predictions of what the mutations might result in the protein. And so with that, I'll take any questions. I put some up here that Caitlin gave me. I was able to answer some, but I'll do my best on the others. But yeah, if there's any questions, please let me know. Joe.
Thanks so much for all the background and for all the work. I have a practical question.
Yeah.
So you mentioned a couple of times. Thank you. You mentioned a couple of times how advantageous it would be to have other university and research partners, and I'm picking up what you're putting down. You want us to kind of lead the effort, and I guess practically speaking, what might be like our elevator pitch? Because I think a lot of us without a medical background, we lean toward empathy approaches, and we come as the concerned father, and that works in a lot of ways. But I think when speaking to researchers, I'd like to be able to say something that appeals to them in another level, I'm gonna encourage you not to hear this as asking more work from you, but
I'll do it.
even if there was like a one-page primer, like a form letter that we could share, because I'm willing to bet many of us have friends that are in universities or university connections, and if we just had a one-page letter that we could share with our friend that could put it in the right hands, that might be helpful.
I can do that for you. I think the main pitch I would make is there's some core symptoms that we would love an expert to do. And my pitch to them would be, there's 3 of us in the whole world working on this on the research side, and we're all very friendly. But there's so many things I can't do. There's so many things that, for a research lab, what would be appealing is knowing there's no competition. Because if I also study TSC and NF1, tons of competition. It's hard to convince someone to help me with those. But when I've gone to my collaborators saying, I have this really ultra rare mouse, no one else is working on it. If your grad student or your postdoc does it, it's a guaranteed paper for them. And they would be very, very excited about that. The good thing is, yeah, the mouse is made, it breeds really well. It's just about having an expert that knows how to do some of these more like peripheral symptoms like gastrointestinal, or even more work on the jaw and the craniofacial. If they've got someone that could do that real quick, it'd be like the pitch is like, for a student or postdoc, it's a guaranteed paper for them. And I wouldn't mind putting something together, and maybe I can get help from Dr. Shinawi about all the symptoms that we should really be looking at. Yeah, thank you.
As a researcher that was basically pulled into it by participant Amanda Smith, it's also finding connections with folks who work on the sort of molecular and mechanism side, which is more my focus, work on related biology and might not even be that aware of the disorder. So I work with some patient organizations that go out and look in the publications for connected, and we could help with this, connected research that might not be obviously Dessh research, but WAC or RNF 2040. I'll tell you a little bit about those. We can talk more about it. Because they may have existing research plans on these, and if they have a disease that is relevant, sort of unfortunately with research, with everything, you need to raise the money. And if there's a relevant disorder, and they're already working on this, and if they work on it in a slightly different way, they can go to the NIH and say, I'm working on a rare disorder, they can raise money. So it's worth going through the literature with your scientific advisory board and saying, who are the individuals that might be connected? I can go to them and say, you work on something similar, can you bring your research a little closer to Dessh, and that will help you raise money, and then start coming to our conferences. And that's how I've gotten involved in 2 different disorders effectively, because I have this sort of molecular research expertise, and then either found those opportunities or been pulled in by someone and said, you would be good to work on this. So, and we could help with that. It's, sort of sort of alphabet soup of molecular gene names, so it wouldn't be as obvious. It's not, oh, there's a Dessh researcher, we should have them come, because they don't even know they're Dessh researchers yet. It's again, these sort of molecular connections. At least at the level where we're working, that is another way to do it, and it's been effective for other organizations. So, oh, and I'm Harrison Gable, by the way. I'm about to talk.
Yeah, just to say that, like this list we're going after now, as we get that, that's a really good point. Because if we do find these candidates are changed at the protein level, then we can go and find, we'll probably end up contacting these people anyway, because we might want their mouse or their rare resources. So yeah, definitely, we'll try to drag them in, but I think that's a really good point.
Okay, so we're running a few minutes behind, so I'm going to limit this to the last question, and then when we get to Harrison's presentation, I'm sure we can follow up with some of the same.
So basically, my question goes to 3, 4, and 5. Essentially, so understanding all the characteristics of Dessh and reproducing them is great, but we're looking for a cure, right?
Right.
And so, like my fantasy, and I told everybody last year that, you know, I hope we can take CRISPR technology and reproduce, you know, 1/2 of the good stuff and just make a fuzzy pumper barbershop mold and fix it all. But like, how do we take this and look at druggable targets and therapeutics versus cell manipulation versus like in real normal English that, I mean, I've got a medical background, but I'm not a geneticist or anything like that.
I think the hardest thing is delivery. We can, in mice, in our organisms, we can absolutely deliver the WAC gene back to these cells. In humans, we can't do that really well right now. People have tried viruses. The problem with viruses is you might build up an immunity to it, so you may only get one shot. There are other delivery methods. We actually just witnessed a huge revolution in mRNA technology that might be possible. That's what I'm thinking. The models will tell us if it's possible. That's what we're hoping. But it's one of these things where the delivery has to be good. The idea of going after druggable targets is great, because if there are FDA-approved drugs out there and we can help with some of the behaviors or some of the learning, that would be our immediate goal. That would be the easiest. I've been thinking about this since I was in grad school, and I won't give my age away, a long time ago. But this has been a problem since I've been in grad school, and the viruses have gotten a little better. CRISPR technology is now being used on blood disorders, sickle cell anemia. I'm thinking single cell again. But that's being used. There's 2 other instances where I know they're going after hereditary blindness and deafness, because those are really easily accessible. Oh, yeah. But yeah, I think that is the big thing. We need better delivery technology, and that's one of the frustrating things that I don't think is very good right now. And viruses are kind of the best option. The good thing about the WAC gene is it's not that big, so it would actually fit in an AAV, which is like I work on NF1, and that thing is so big we can't deliver it even with the lentivirus. They're the biggest that I can deal with right now. But AAVs would be suitable for the WAC gene. The question is, would one delivery be enough? We are trying this right now, and I think Harrison's lab is also doing some complementation assays where we're trying to put back in the wild type version to see what we can fix, and then put back in mutant versions to see what different phenotypes they're responsible for. Yeah, we're trying it in our assay because we think there's actually a growth problem in some of the cells. Like they may not be growing enough. So that's a really good assay to like try to fix it with different versions of the WAC proteins. Yeah, so we have a human version of the gene right now that we're trying to introduce and manipulate. No, it's a great question though, because it is one of the most frustrating things is trying to find a good delivery system to put it back in. Yeah.
Thank you so much to Dr. Vogt.
Thank you.
Oh, you leave it open because it's all.
Oh, sorry.
That's okay. That's okay.
Okay.
There's Christopher Leonard. We need Chris. Share screen. Yeah. No, I think it's for our. Oh, that's 2. Perfect. Share again. Okay.
Oh, okay.
all set. And you should, oh, you're right here. You're right next. Okay. Without further ado, I'd like to introduce Dr. Harrison Gable. He mentioned, I think we got it back up and running. You tell me if I'm wrong. So I'd like to introduce Dr. Gable. He mentioned, and so did Dr. Shinawi, Dr. Amanda Smith, who had originally started work on the WAC gene here at WashU, and it has since been given to Dr. Gable to sort of work and develop I've been warned, a deeper, more difficult way to listen and understand. From a science perspective, this is going to be tricky. so have patience, be kind, and I think it's really important for us still here to be able to hear Dr. Gable's presentation. So thank you for being here.
Thank you very much. Everyone hear me okay? I'm going to oddly start with an answer to the additional information about the last question. So I work with two other rare disorder groups, the Rett Syndrome Research Trust and the TBRS community. Rett syndrome is entering, patients have been dosed with gene therapy. That's way out in front of where gene therapy is for most disorders, but we're learning a ton from those trials, and I think those will tell us a lot about what the future holds in disorders like Dessh. I do want to say that those are, there are reasons why those trials would go forward, that where in something like Dessh, you'd want to wait a lot longer and understand things a lot more. However, the really interesting thing about gene replacement therapies is they basically, what you learn in one disorder, you can apply to another disorder because delivery ends up being the same. And there are a ton of companies now working in that space. So I would imagine we'll see delivery get a lot better with time. One really important experiment I think should be done in every neurodevelopmental disorder is asking if I can put the gene back perfectly with a perfect gene therapy. Let's let the biotech companies develop that. Will it be as effective as I want it to be? As Dr. Vogt was talking about, if there are changes in early development, then if you put the gene back, that won't necessarily be corrective. And the cost-benefit analysis of gene therapy is there. So one thing that actually I would propose we maybe try to put together is a mouse where you can turn the gene back on. This has been done in a couple of different disorders where we would start with a Dessh mouse, and then you can, in an engineered way, do perfect gene therapy in that mouse and ask how much better the mouse gets. So that would be something, if you guys are up to it, would be great, where we could think about how we could basically build that mouse. We just built it for another disorder we study. And that basically is a signpost. If gene therapy I can do gene therapy perfectly, will it improve the disorder substantially? And should it be something we invest our time in? Or should we be thinking about other ways of treating the disorder because the gene itself, the loss of the gene early on in development had a big enough effect that we can't put the genie back in the bottle. It's not, if gene therapy was easy, we wouldn't ask that question, we would just do the therapy. But if we're trying to do cost-benefit analysis of risk versus reward, that can be quite valuable. And I would also note that I guess the other place where I see Dr. Vogt's results already giving us some ideas is, each of those receptors, the genes he saw changing, they are receptors, and he was talking about them being druggable. So that does give us ideas about how we would start going after drugs. Those are two ways I can see sort of very basic research in the mouse and understanding, if the gene if it's replaceable late, if that helps, and finding targets that we could go after. So sorry, that was a really complicated answer, and now I will introduce myself. I'm Harrison Gable. I'm a researcher here at WashU. I just moved into the big neuroscience building down the street, and I'm very excited to be here and meet everybody. We are brand new in WAC research and Dessh, so I'm going to be telling you about what we're doing. It's basically a year and a half worth of work getting into things, or maybe it's been longer. The pandemic made everything seem shorter. Unfortunately, Alyssa Erickson, who's really the engine for this work, who's a grad student in my lab, can't be here. She really wanted to be here. She had met some folks in past years. She was ill today, so she's not here. So I'll tell you a little bit about our lab. We started the lab in 2015 here at WashU. Again, that feels like yesterday, but it's not yesterday anymore. And really, I studied gene regulation in the brain at Harvard Medical School and got my PhD there, and did a postdoctoral fellowship there, and really developed an expertise in understanding how genes get turned on and off in the brain to help the brain develop and to help the brain function. And I'll tell you why that's relevant for Dessh and WAC research in a minute. But we're trying to understand basic mechanisms by which the brain functions and turns genes on and off to do those functions. But it turns out that understanding those basic mechanisms, sort of the way molecules inside cells turn on and off genes, is really important for understanding multiple neurodevelopmental disorders, because often that process is disrupted in these disorders. So it will be a deep dive into molecules and genes, and I hope that's helpful for some background. Hopefully it's not too long, so it won't be too painful right before lunch. So there's Alyssa. She's the one that's been doing the work, really remarkable, talented, brand new researcher. So as I mentioned, we study gene regulation, and from a fundamental perspective, the way you build a big complex human brain is that, as Dr. Vogt really nicely introduced, you have to take the DNA, which is where the genes are encoded, and turn it into little molecular machines. Go through the recipe and make these proteins that are little molecular machines that are inside the cells and helping cells do their functions, right? So the process of building a brain is really a readout problem using the human genome and turning on the right genes in the right place at the right time to build a very, very complex system, right? Billions of cells that make trillions of connections. If you look inside the human brain, there's many, many different cell types, in particular, many, many different neuron types. So all these different colored cells are different types of neurons that do different things in the brain. And really, for those cells to function, they have to turn on the right complement of genes. It was mentioned that there are thousands of genes inside of cells, and you turn on a percentage of them, maybe 30 or 50% of them in every cell, and you have to turn that gene on in the right place, the right time. For example, for an excitatory cell, Dr. Vogt was talking about how neurons have excitation and inhibition. An excitatory cell that propagates signals through circuits in the brain has to have, let's say, gene A and B on, but not gene C. And an inhibitory cell that sort of puts a brake on that and might stop things like epileptic events from happening, it might need gene A and C, but not B, okay? And this has to be a very choreographed process, really precisely, in order to build the brain during development, in order for the brain to function. And in neurodevelopmental disorders and genetic disorders, often it's the dysregulation of these genes, and as we heard from Dr. Vogt, that's going on underneath it all and driving some of the sort of altered functions in the brain. And that's because in these genetic disorders, let's see, do I have a pointer? I'm going to try to use a laser pointer. Is that there? Yeah. So in these just genetic disorders, it can be that the things that turn on the genes, turn on and off the genes, are disrupted. So you're inside the cells, the right genes are not being turned on and off at the right time. In fact, human disease genetics, and particularly for neurodevelopmental disorders, like the type of discoveries that Dr. Shinawi has been making, has had this rapid acceleration in the discovery of the genes underlying these different disorders. That's why we found the genetic basis of Dessh. And this has been going on now at an enormous scale, and hundreds of new disease genes have been identified. And strikingly, even though these are disorders that affect the brain largely, and you might expect them to be little parts of the neuron that help communicate, the genes that are actually usually disrupted in these disorders, or in a large percentage of the time, are actually genes that help turn on and off and regulate the other genes in the brain. So they're sort of master regulators, right? And they're helping turn genes on and off. This is what we think, at least part of what WAC does. This is its function. And my lab has been studying these regulator genes in other disorders for quite some time. Dr. Amanda Smith was looking to expand the research plan and then moving on, and came to me and said, you're really well suited to study what we think might be the molecular function of the WAC gene, to help turn on and off other genes. So if we really want to understand what happens in Dessh when it's not there, you might be able to dig into that. And so that brought us into doing these studies, because we feel like we have a really good set of skills and expertise that can look at the very basic function of the WAC protein and sort of from the bottom up tell us what's going on. And that really meshes really well with Dr. Vogt, who's thinking about the cells that are affected, the circuits that are affected, and the sort of downstream effects. And why is that important to know? Well, understanding the disorder in general, and more knowledge is always valuable. And in the long run, as we think about the potential for things like therapies, molecular mechanisms can be used as handles to think about therapeutics. So if we know the fundamental function of the WAC protein, we know at its basis what might be going on, in the disorder, and there are ways of trying to manipulate at that real base function of the WAC protein. Not always, as we were just describing, but sometimes. And so, being totally focused on understanding Dessh, that's where we think we can provide some knowledge. It's also sort of fundamental biology that we need to understand better and may have an impact across disorders. So Dr. Vogt mentioned WAC working in the nucleus of cells. Just wanted to quickly highlight that where genes are. So genes are in the DNA. They're a long list of bases in the DNA. The DNA of any one cell is about 6 feet long, and it's packed into a cell, into the nucleus of the cell, that's about 10 microns, which is, absolutely tiny. So that genes are all in there and they need to be used, read out. And that's an incredibly challenging problem for the cell. It has to make the genes available to then produce all the proteins we talked about. And the cell needs mechanisms to do this regulation. And this is where we think WAC works. In particular, genes are wrapped up in little packages called histones that help basically compact the DNA. And gene regulation depends on those histones being changed chemically so you can turn genes on and off. And this is where we think WAC is working because of previous literature from researchers that weren't thinking about working on Dessh, but were working in yeast cells and trying to understand what does this protein do? And it turns out it's the same protein, the WAC protein. So studies from yeast cells and some cell culture, sort of cells just growing in a dish that aren't as relevant to the brain, have shown that WAC can work together with this little molecular machine, including these other proteins. They all have names. And one of its functions appears to be doing this chemical modification of proteins that help pack genes together. This is why we think it might regulate gene expression, be a master regulator of gene expression. And so there's this good evidence that it's doing this in other systems, but no one's looked at it in mammalian neurons yet. And we want to know, if we really want to know in terms of the behavioral impact in Dessh, what its function is in the brain and in neurons. So we've made that our job, understand what WAC does in neurons in the brain. I should mention that these histone modifications, this is getting pretty technical, we know what some of them do. They help to turn genes on and off. It's as simple as that. But with this modification that WAC has been suggested to do is a new modification that is not very well understood. So we're really studying basic biology of how genes are potentially regulated in different ways, including turning genes on and off. So we're really, when we're studying WAC, we're really digging into fundamental new biology at the same time that we're understanding what goes wrong when WAC is gone. So how are we going to do this? Well, we're using a very similar approach to what Dr. Vogt has been using, except with one sort of major change in terms of the first experiments we were doing. So he made what is the most essential first experiment to do when you start studying a disease gene, which is make a model of the disorder. So eliminate one copy of the gene and say, what do we see? Does the mouse have changes that look a little bit like the disorder, so we can use that to understand the underlying basis of the disorder? But if you're trying to understand the function of a gene, sometimes it could be more powerful to completely eliminate the function of the gene. So take out both copies. This is not what happens in the disorder, and it's very, very severe. But because the effects are bigger, we can get a better understanding of it. And then we can bring that back to what we call the heterozygous model, where only one gene is deleted. And we can use that information we got from this very clean, very severe experiment to then bring it back and understand when partial loss of the gene occurs. So what we've been doing is trying to knock out WAC completely in neurons and study what happens to this sort of candidate molecular mechanism, this change in histones, and then how that affects how genes get expressed. Very similar to what Dr. Vogt was describing, where he studied how genes change in the brain. And this is just sort of justifying why we think a complete knockout approach is very complementary to this partial knockout approach that is the true Dessh model. So how we're doing this is using the same actually sort of genetic construct we got from through Amanda through the same initial knockout consortium. So these consortia provide really valuable reagents. And what we can do is we can, instead of having the mouse a mouse where only one copy of the gene is ready to be deleted, we have both copies ready to be deleted. And we can take the mouse itself, or we can take neurons we've isolated from the mouse and we're culturing in a dish, and we can treat them with something called Cre recombinase, which leads to the gene being completely deleted. So now we've completely removed the WAC protein, or I'll show you that we've done this. We first, as scientists, need to validate that we've done that. And then we can say what happens, right? In order to have very tight control of this, a lot of the experiments we've been doing is actually taking neurons out of sort of very young neurons from mouse embryos, placing them in a dish, and then doing this treatment and rapidly looking right after we eliminate the gene what happens. This allows us to understand exactly what the gene does without all these sort of downstream effects that can occur. So this is what we call a reductionist system for understanding the function of the WAC gene. So what happens when we do that? Well, can we delete the gene? Yes. Sorry for additional data, but this shows how much of the gene is gone. We get rid of almost all of the gene with this deletion. And then this is a way of measuring how much of the gene product, the protein that does the job of WAC, that's produced from the gene, how much it's gone, and we can show that that's also gone. So we've eliminated the function of the WAC gene in these cells, and we have a lot of confidence that we've done that. So what do we see? Well, we see that this H2B ubiquitin, which has been hypothesized to be what WAC helps put in, goes away dramatically in the knockout mouse. The KO stands for the neurons. KO stands for neurons that no longer have the WAC gene. And this H2B ubiquitin, which is this chemical modification on the proteins in the DNA in the nucleus, is gone. So this is sort of the first step to saying that, yes, in the brain, this is what WAC does. A major thing that WAC does is to make this chemical modification on histones. Okay, so we're doing a number of studies, and I don't want to get into the details too much because it gets pretty technical, but we're doing a number of studies to say, where is this chemical modification normally in the genome? What genes does it help regulate? What's the entire molecular mechanism that it does that's missing when you get rid of WAC? And I'd be happy to talk about that, but it gets quite technical, so I'll move on to sort of the consequences of it and what we think it might mean. But we're very actively, sort of now that we've established a fundamental function for WAC, studying that, because we think it's something that is going to be affected in Dessh. And so we're studying those underlying molecular mechanisms. What about the effects on genes? And this is where Dr. Vogt and our data is starting to overlap in ways that was really valuable because we can believe what we're seeing. So what we did is then measure the production of all the other genes. So if WAC is regulating through this H2B ubiquitin all the genes in the genome, then a whole bunch of other genes shouldn't be functioning as well, right? Pardon me. Shouldn't be being produced to the same extent. So we did a very similar experiment to what Dr. Vogt was describing in our cultured neurons that have no WAC, and we get a whole bunch of genes that change. They're not being produced at the right levels. How is this relevant to the function of the nervous system? Well, if we look at the genes that are changed, there's a large number of genes that function at right where neurons communicate with each other, at synapses. So synapses are the connections that neurons make where one cell can excite a downstream cell by releasing neurotransmitters and causing activation of the next cell. So these are the proteins, all these genes that are changed make little molecular machines, little proteins that help the cells communicate with one another. And if we think about the sort of cognitive challenges or other neuropsychiatric challenges that are happening in Dessh, changes in these types of communication machinery could be driving some of these effects. So we're hard at work trying to understand exactly how that change in the sort of molecular mechanisms, that H2B ubiquitin, is leading to this effect. One other area where we've started to try to look, because of some literature that was out there, some publications, again, outside of the nervous system, outside of what anyone would consider Dessh research, they gave us some clues that we should look at something closely where we've seen some interesting results. And in fact, this is where, this is the first meeting I've been at, and people are talking about certain types of symptoms and behavioral challenges and dysfunction in the motor system that is actually suggesting that we're looking into something on a molecular level that might be quite relevant. So I'm already picking up from what you guys are sort of hot off the press saying they're observing in the clinic. So it's going to motivate us to dig more deeply in the lab. I would say, having done research in rare diseases, I've been, first of all, incredibly impressed by the organizational power and getting the clinic together that you guys are doing. And I think it's an enormous engine for research. Even if I just come and I observe what you're learning and the motivation you have and the sort of the imperative, and I bring that back to my lab, it's incredibly motivating. But also, I've already picked up on several things that's going to change the way I do my very, very basic molecular research today. So, thank you for those contributions. I know that's not necessarily why you're here, but that is driving our research as well. So, okay, so back to this very technical aspect of things. What we decided to try to look into, my student Alyssa actually made the connection, was neurons don't just have genes on and off that help them function. They actually have been shown to respond to stimuli by turning on new genes. So if a neuron in a brain gets activated, it turns on a set of genes that helps it tune its function and in certain cases, for example, become less active. So if a neuron's firing too much, it will turn on a bunch of genes that say, you should turn down your ability to get excited and to fire because you're firing too often. And some of those mechanisms are actually involved in things like stopping hyperactivation of the brain, and when they're disrupted can lead to things like epilepsy. So I don't want to say that this is immediately going to explain where some of the seizure activity comes from, but what we're looking at here in terms of gene expression being turned on when neurons get excited is certainly relevant to those phenotypes that we're hearing about, those symptoms that we're hearing about. So we decided to, instead of just look at the genes that are on in neurons and how they change when we get rid of the WAC gene, we decided to stimulate the neurons and ask, what's their response to stimulation? This would be sort of mimicking plasticity or sort of hyperactivation in certain types of stimulus in the environment, or visual stimulus that would help the vision system develop in the cortex. And so the way we can do that, last two bits of information, there is a little evidence that H2B, which I've told you WAC is helping to do, might be involved in this process of turning genes on and off quickly. So we wanted to see if this is affected in neurons. So we took our system where we can take the WAC gene out and see if things are changed, and instead of just leave the neurons and measure what's different, we actually stimulated the neurons by putting a potassium salt on them that basically makes them all fire all at once, and then we can watch what happens to the cells. And the cells turn on a bunch of genes. So in the gray, again, sorry, a little data here, but in the gray lines is what the cells that have the WAC gene do, and this is the expression of two genes after we stimulate them. And so this is showing that the gene gets turned on. And this would be under the normal process of sort of plasticity in neurons. When they fire, they turn on this gene. But what you'll notice is when the gene is missing the WAC, when the cells are missing the WAC gene, that's the KO cells, they have more expression of these genes that are supposed to come on and then go back off. So we think the WAC protein and what it's doing in cells is helping to regulate the dynamics of genes that turn on and then go back off again when you get stimulus from the environment. Why is that important? Well, this process helps with plasticity, it helps with tuning circuits, and so if it's not working quite right, it could be contributing to some of the things like seizure activity, or we were hearing about cortical blindness and certain types of visual acuity that were not functioning correctly in Dessh patients. This dysregulation, this problem in the cells, is possibly being driven by, is driving some of those effects. And now as researchers, we can go and ask, is it possible that this is driving it? So we now have the inkling of a hypothesis about where some of the challenges in Dessh are coming from. Very early days, but it's interesting to see that potential connection coming out, and it's something we'll start looking into. So what do we want to do next? Well, we want to bring it back to the Dessh model. So to go back to the mouse that has 50% protein and ask, what did we learn from the cells that had no WAC protein? And then, does that same thing happen to a little bit of the same extent in the cells that have only 50% WAC protein? And we can do that because of the great models that Dr. Vogt has developed and that we know are really a really good representation of what's going on in Dessh. And then in these models, we want to basically stimulate transcription, stimulate the genes to go on, and ask
if they change in models that are sort of mimicking the types of challenges and stimuli that you would get in the environment, like motor activity or visual stimulation, things that are essentially things that would turn on these gene expression programs. The last thing I want to say is that I know there's been efforts to collect biospecimens, and what can that do for research? Well, the interesting thing about the work we've done so far in cells is if we can get biospecimens from patients with Dessh, we can go do the exact same experiment in human neurons and validate that what the mouse is telling us is actually something that you see in human cells. And that's a really critical aspect that the patient community can contribute to provide those reagents that allow us to double check our math, basically, from the mice and go do studies in human cells. And then if that validates, we know that it's quite relevant to the disorder. So in the long run, we'd be interested in doing that to potentially sort of bring it closer to the clinic. So I think you've probably had enough of the technical stuff, but this is the summary of what we've found so far. We can knock out the WAC gene entirely and study it in neurons, and we think that we've sort of confirmed and extended what was suggested by studies outside of Dessh research, that one major and important thing that the WAC gene does is to help modify histones in the nucleus and to help to regulate gene expression. And in particular, this might be really important for turning genes on and off when neurons are responding to stimulus. And as I mentioned, these are our future directions, and we think that if we can build from the bottom up, we can provide insight into the sort of fundamental function of WAC, and that can start to inform the sort of what we understand about how the disorder arises and set things up for thinking about things like therapeutics in the long run. And I'll just finish there by thanking all the folks in my lab. It's really, Alyssa Erickson has been the driver of this research from the beginning, and has really made it possible for us to start participating, and I really appreciate the opportunity to present her work today. And then, of course, Dr. Schnawi and Amanda Smith, who got us in, and we've been having great conversations, Daniel Vogt and I, and we've been having sort of Zoom meetings with the Korean researchers, and we're trying to build the most collaborative research community we can get, so we can be exchanging information as quickly as possible. And I think we've really launched in a great way, and I want to thank you guys for bringing me in and continuing the conversation. So thanks very much.
Thank you so much, Dr. Gable, for your work and your contributions. And I wanted to open it up. If we have any questions for Dr. Gable, we can maybe take a couple, one or two questions. Otherwise, we'll jump into the next slides. I'm sure you're willing to maybe share your, I could share your information or
sure,
perhaps speak. Does anyone have any questions while we're still here?
So is there a timeline when we'll fully understand the basic function of the WAC gene? So when our son was diagnosed, when I was reading the article, it was said that it's not really known what the functions of WHA gene, but after listening what you were saying, looks like there has been a lot of discovered. So just wanted to know if there is any timeline that can be, but it's really a research thing, but just wanted to know.
Right. That's a tough question to answer as a researcher because we can't really predict the rate at which we can make discoveries. What I would say is in my lab in particular, we're really accelerating, and we feel like, in particular, this molecular function of WAC in H2B ubiquitin that I've just been describing is something that we have a very good handle on. We'll be able to make progress on very quickly. It's hard to say that that's the only thing that the WAC gene does, right? And so that's a difficult unknown in research. But over the next few years, I think we're going to get a very good handle on this particular function of the protein, and then the hope would be that that will start to immediately have some insight into the nature of Dessh. But so I would say we're accelerating. I can't give you a finish line and say, oh, we'll cross it in 5 years. I do think things like modeling gene replacement
and seeing how replaceable the gene would be, could be put on the initial experiment could be on a three-year time scale and could provide valuable information for you as a advocacy group saying, we should pour our therapeutic ideas into this area, where we're going to try to correct the function of the brain, or we're going to try to correct the gene. So I think those types of experiments can be really valuable in terms of prioritization. And I'd be happy to sort of think about contributing to that and how we can do that. So that could have a more defined timeline over a few years.
When you first started speaking, you mentioned something about you would like to know if there's interest, or hopefully it's something you'll start very soon, would be to add into the adult mice that have already grown with half Dessh or half WAC, like you would add a normal, another protein. When can we expect to see, because I think we would all really love to see the results of what that looks like as an adult, to see if it's worthwhile to,
Yeah, so I think that is a really important priority, and if I'm not doing it, we should be doing it somehow. And there are a couple different ways to try that experiment. They are all going to operate on the order, if we started today, and it might be that there are folks out there that may have already started on this experiment, it will be on the order of a few years before you would know that. Maybe on the short time scale, 2 years, on a longer time scale, 3 years, something like that. You need two things to do that experiment: a really good way of delivering the gene, and we talked about some of them, and there's some not so perfect ways of doing it. And then there's the perfect way, which is to make a mouse. And that would take, in this day and age, maybe a year to do. And then you need phenotypes. You need things that you're going to measure whether or not they get better in the mouse. And that's where Dr. Vogt's work is so important, is categorizing all the things we can see in the mouse that we can measure as changed, because we want to see if those things come back. And so you need that sort of, and in the long run, when thinking about therapies, things like outcome measures effectively. So you need those two things to be built up, and that takes sort of reagent generation, funding, things like that. So I think, and the timescales of those are a few years. But I think we can certainly brainstorm about how one would do that if there's already things underway that would give you a lot of that same answer. You can deliver the gene in a less perfect way than making a mouse with a virus, for example. But I do think that's a really fundamental thing to be doing. The second part we need is the readouts, right? And good readouts tell you whether or not you've actually corrected things. And sometimes in the mouse that can be hard, because mice are not little humans. Their phenotypes tend to be less obvious. Their symptomology tends to be less obvious. So having really good outcomes in the mice is valuable. So we can immediately start talking about the ways in which one would attack that, and then think about funding. We can work on that together as well. So.
Last question.
You mentioned about FDA-approved medications already for other diseases or other mutations. What is the outlook for taking a medication as an adult? If you were to find a correlation and find a medication that we could apply, how beneficiary is that to an adult?
Yeah, I mean, I think it really depends on the details of the biology and the disorder. I mean, that is the fastest way to effective therapies, and I would actually defer to Dr. Schnaue after I finish the sentence on repurposing of existing drugs. There are so many drugs out there, some of which are obvious to try. You heard about some. Yeah. But there may be things that come out of the gene expression studies that Dr. Vogt's doing that says, oh, this pathway, which is hit by this drug, we never would have thought of would be an effective therapy. It's a drug. You can try it. You can go off-label and try it. Yeah. Those types of things can happen much more immediately than a genetic therapy, which is not yet proven in these types of disorders. So I think there can be little inklings of ideas of how one might do that from the type of research we're doing. It would then go to the clinicians who treat your loved ones with the disorder to look at those possibilities, but information being sent out by the researchers saying this might be something you could look at would be a way to move forward with those kinds of approaches. So yeah, that is probably the fastest way to something more effective, is to get some clues from our basic research that, oh, we should be using a drug that we never would have thought of, because you can't try every every medicine, right?
Right.
And that's, our hope would be actually, that comes out of our research pretty immediately, and that could move forward. And it's not unheard of, but you have to have a little bit of serendipity and the right connections. But yeah, that is a viable path forward.
Yeah.
I don't know if you would have anything else to say about that.
Thank you once again, Dr. Gable. So we're at the home stretch. Round of applause for home stretch. I had a few slides I wanted to go through about the foundation, but I'm really just going to hit on a couple of important ones. The purpose of our foundation is we're dedicated to the care and advocacy of all of the DeSanto-Chenaui syndrome patients. We started in 2019. We got our 501c3 in 2020. Since that time, we've been able to raise upwards of $100,000. This, again, is a little bit more of that timeline. And this here pretty much sums up our mission statement. We are driven by the desire to make a positive impact on the lives of those affected by Dessh. One of the, here, I'll just jump to this. So the values that we hold here at the Dessh Foundation really clarify what matter most to us. They define our priorities and what we're willing to commit to. These really give meaning to our mission and goals. So number one, we believe in the power of the patient. And I think that's something that has been backed up today by all of the clinicians and researchers here. That patient-led research organizations are vital because they empower individuals directly affected by Dessh to drive research agendas, advocate for our unique needs, and accelerate progress toward treatments and cures. So when we can share our lived experiences, we ensure the research stays patient-centric, relevant, and impactful. As a patient advocacy group, we really bridge that gap between science and the human experience, which again was evident today. I don't know if Drs. Vogt or Gable had met any Dessh patients prior to this event. And it already is going to inform some of the things that they take to the lab with them. So number two, we believe in the power of data. Data plays an indispensable role in rare disease research, and the importance of quality data can't be overstated. It really provides the foundation for comprehending and understanding the intricacies of Dessh and how it varies throughout our community. Accurate data is what we are all craving as Dessh families. That is apparent with all of the anecdotes that we share with one another across our WhatsApp groups, but what we need to advance the research is really measurable patient data. And that's going to become our compass to illuminate our path toward treatment. And number three, we believe in collaboration. The Dessh Foundation's central role is bringing together all of the stakeholders that it's going to take to move the needle forward on progress towards treatments. We foster these collaborations to create unified and powerful force for change. We collaborate within our organization as well. There's no silos between our medical board and our Dessh board of directors. Committee meetings often share members, and information is constantly being passed around. So this is the patient advocacy group's central role. We are like the hub. We are the hub of the wheel, and these are all the people that are important on our mission. And so we bring all these stakeholders together. Obviously, the patients and families, you guys are the core of the group. And then medical professionals and institutions, everyone that we met here today, the researchers and the scientists from our research labs. Also policymakers and government. It's last Rare Disease Day. I went to Capitol Hill with other rare disease patients as part of a Rare Disease Day, and we met with members of Congress to advocate for regulatory changes, influence healthcare policies, and increase research funding. So it's important that they hear from us. Obviously, the donors and philanthropic organizations that can keep our lights on, keep events like this possible. It's important that we can make meaningful connections with these types of groups. And we have an amazing group of volunteers and community members. Many of them are on the third floor right now, caring for our children and bringing entertainment for them, and also people that help in our community with our social media campaigns and social media management, and local businesses that offer us sponsorships are all included in that. And there are a lot of other people sort of not mentioned on this group that we are also have connections with. In the future, we will need to form connections with pharma and biotech companies, perhaps expand our global network to have a more formalized Dessh group in different countries supporting the different governments and systems of medicine there. And obviously, we want to be in touch with media and news organizations. Raising awareness is so super important, so keeping in touch on delivering out education to the broader world is part of our mission too. Our goals and strategies. So these yellow boxes did have titles in them, and I'll just read the titles to you now. So we have 5 goals. Or the first is supporting all of you, the patients and families. Next is raising awareness. Next is advancing the research, which I'll get into on the next slide. Of course, fundraising. And lastly, we care very much that we have an organizational excellence. We really care that our organization is strong enough, because all these initiatives really rely on the people that are here supporting and working towards all these goals. So I am going to take a deeper dive quickly into the research. So as we just heard, the fastest way to a treatment these days right now is a drug is a drug therapy. And so the Global Genes is an organization, and they've put together this path, and they call it from bench to bedside, or research lab to patient. And this is sort of the pathway or the road that all patient advocacy groups sort of take if they are trying to develop a drug therapy treatment. I won't go into the details here, but I will tell you where we are. We are here in the bottom left-hand corner. We have a body of basic research on Dessh because of all of our collaborations, and we have a toolbox that really consists of our animal models, our biospecimens, and this clinic, which we will turn into our natural history study. And then lastly, a bit of I'm going to elaborate on a critical piece of research that we actually need everyone's help with. It is our patient registry, and I actually have a pre-recorded quick couple of slides from our board member, Amanda Murphy, who's going to speak about the launch of our patient registry, which is coming up at the end of the fall.
Hello, everyone. My name is Amanda Murphy, and I'm on the board of directors of the Dessh Foundation. I hope you are enjoying the clinic so far. I just wanted to take a couple minutes of your time to discuss an exciting new opportunity, the launch of our patient registry this fall on the RareX platform. Your participation is crucial to the success of this data collection. So while we will have a lot more information coming closer to the launch, we just wanted to put this on your radar now. So what is a patient registry? A registry is simply a collection of data or information about individuals, usually focused around a specific diagnosis or condition. That's the NIH definition. So here, DeSantos-Chenaui syndrome is the condition that we are interested in learning about. That data is collected on a patient registry platform, which functions as a means to easily collect, access, and share patient data with doctors, researchers, or drug developers to fuel progress within and across our rare disease. So why should we have a patient registry? Well, scientific researchers, the pharmaceutical industry, and FDA all agree that data from each patient's medical history, genome, and other sources are critical to disease understanding, diagnosis, treatment, and the development of future medicines and cures. So this is our opportunity as patients and caregivers to contribute information crucial for scientific researchers to access and use. Basically, our opportunity to push the science forward and eventually develop treatments. So we have partnered with RareX, a nonprofit dedicated to providing resources to patient advocacy groups to fulfill these goals. And I thought it was fitting that their motto is patients' data powering progress, because that is exactly what we want to achieve with this patient registry. So as you can see from this slide, RareX is committed to removing barriers to access for reliable and comprehensive patient data. So RareX equips patients to share their data with global researchers, clinicians, and drug developers. And of course, the data remains completely patient-owned. And RareX, of course, is also compliant with all applicable national, international, and state-level privacy laws, including GDPR, HIPAA, and basically any law that our patients, of the countries that our patients are located in. And of course, best of all, there's no cost associated with the use of RareX platforms, no cost to patients, no cost to patient advocacy groups, or scientific researchers. And, we just wanted to emphasize here that this is our patient registry, and we hope that in addition to if enough people participate, that in addition to the creation of data useful for scientific researchers, we hope the data will also be helpful to empower patients and caregivers at the doctor's office through the creation of data visualizations that will help paint a better picture of what Dessh looks like for doctors who are often completely clueless when it comes to De Santo-Schnauwy syndrome. RareX is also going to roll out Spanish translations of the registry forms and surveys very soon, and Portuguese and French translations are also on the way. Again, this is just a very small amount of information to whet your appetite, to put the patient registry on your radar, since your participation is crucial for it to become the powerful tool it has the potential to be. More participation equals more data available for scientific research, more and better data available for scientific research. So stay tuned for our 2023 launch and get excited. There will be a lot more information coming. In the meantime, please feel free to email me. I have my email on the slide right here. Email me with any questions and enjoy the rest of your time in St. Louis.
Bottom line, join our patient registry. There we go. A few key dates and upcoming events for the Dessh Foundation that I hope you guys can all get behind. First is a huge fundraiser, Dash for Dessh. That was actually our founding event back in 2019. We've since done an additional virtual event, and we're going virtual again this year. Because we have a global community. We want everyone to be able to participate, and we can all around the world with something like this. Of course, local families sponsor an event locally in your own neighborhoods, bring people together. More information can be found at dashfordesh.com. November 28th is Giving Tuesday. This is a huge fundraising day for our organization. So to the extent that you see anything posted on our Facebook page that you're willing to share with your own networks of people, please do so. And Rare Disease Day is the National Awareness Day for all rare diseases, and that happens on February 29th, and this year is a leap year, so it will be on the 29th, 2024. With all that, I want to thank everybody for joining us in St. Louis for the clinic and for spending your time and resources to grow this research. I'm really honored to call myself a member of this remarkable patient community, and I am deeply inspired by all of you and your strength and resilience. For all of us in this room and those joining us from afar, we share a unique journey. And in the face of a medical condition that really has altered the course of all of our lives, it's easy to feel isolated, overwhelmed, and disheartened. Yet it's in these moments that our strength shines brightest. We're more than just patients and families. We are a community. We're a family brought together by Dessh. Our shared experiences and collective knowledge are huge assets. We have the power to shape research agendas, to drive investment in promising treatments, and to be the voice that resonates with researchers, clinicians, and policymakers. Every contribution matters, whether you're actively involved in advocacy, participating in research, or simply offering support and encouragement to your fellow community members. Your role here is indispensable. It's our collective efforts, no matter how small they may seem, that add up to something extraordinary, and I'm forever grateful to count myself among this group. Thanks everybody for coming today. I do want to invite you all to the third floor for a group photo, for a picture all together, and then I wish everybody safe travels home, and we'll see everybody next year.